did several programs. Many of the programs was in webinar, especially Friday night with rheumatologist. Every Friday, last 1 year. Now I like to show the program of Rheumatology, Bangladesh Rheumatology Society, a video clip for 5 minutes before starting second session. Please, Basudev, please.
চিকিৎসা বিজ্ঞানের অন্যতম প্রধান একটি শাখা রিউমাটোলজি। মানবদেহের জটিল এবং কঠিন সব রোগগুলো নিয়ে গবেষণা হয় এই শাখায়। বাংলাদেশে রিউমাটোলজি সাবজেক্টের বিস্তৃতি, চিকিৎসার বিকাশ, রিউমাটোলজিস্টদের পেশাগত দক্ষতার উন্নয়নের মহান উদ্দেশ্যে 1997 সালে প্রতিষ্ঠিত হয় বাংলাদেশ রিউমাটোলজি সোসাইটি। 2020-21 করোনার মহামারীতে মানুষ যখন দিশেহারা, চিকিৎসার জন্য দিকবিদিক, ঠিক তখন সাধারণ মানুষের দোরগোড়ায় রিউমাটোলজি চিকিৎসা সেবাকে পৌঁছে দেওয়ার লক্ষ্যে বাংলাদেশ রিউমাটোলজি সোসাইটি আয়োজন করে এক ব্যতিক্রমী ভার্চুয়াল প্ল্যাটফর্ম ফ্রাইডে নাইট উইথ রিউমাটোলজিস্ট। সুপ্রিয় দর্শক, আমি ডাক্তার বাসুদেব কুমার শাহ আপনাদের সবাইকে স্বাগত জানাচ্ছি
ফ্রাইডে নাইট উইথ রিউমাটোলজিস্ট অর্গানাইজড বাই বাংলাদেশ রিউমাটোলজি সোসাইটি।
প্রতি শুক্রবার রাতে বাংলাদেশের প্রথিতযশা রিউমাটোলজিস্ট বৃন্দ রাজ টিভির পর্দায় উপস্থিত হয়ে আলোচনা করেন রিউমাটোলজির একটি নির্দিষ্ট রোগ, তার কারণ, চিকিৎসা ও প্রতিকার নিয়ে।
বাত ব্যথা বলতে কি বোঝায়?
আমাদের শরীরের গিরা, হাড় এবং মাংসপেশি ব্যথা, ফুলে যাওয়া বা আড়ষ্টতা, তাহলে আমরা বলবো বাত।
যে সমস্ত মায়েরা সিস্টেমিক লুপাস ইরিথেমাটোসাসের পেশেন্ট, তাদের ক্ষেত্রে প্রেগন্যান্সিতে কি কি ঝুঁকি রয়েছে?
এসএলই হচ্ছে এমন একটা রোগ যেটার জন্য প্রেগন্যান্সিটা হাই রিস্ক প্রেগন্যান্সি।
ব্যথা বলতে আসলে আমরা কি বুঝি?
অপ্রীতিকর এবং সংবেদনশীল অভিজ্ঞতা।
বুকে ব্যথার কারণ কি বাত রোগ হতে পারে?
বুকে ব্যথা অনেক ধরনের বাত রোগ থেকে হতে পারে।
কি কারণে আসলে এই রিউমাটয়েড আর্থ্রাইটিস হয়?
এটা অটোইমিউন ডিজিজ। এটা শরীর রোগ প্রতিরোধকারী ক্ষমতা শরীরের বিরুদ্ধে কাজ করে এই ডিজিজটা করে থাকে।
আসলে বাত জিনিসটাই বাকি
এক ধরনের প্রদাহ, বাংলায় যেটাকে আমরা বলি, যা শরীরের বিভিন্ন অংশে হতে পারে।
নকটার্নাল লেগ ক্র্যাম্পস এবং রেস্টলেস লেগ সিনড্রোম, এই দুটো বিষয়।
রাত্রিকালীন বাত বলতে কিন্তু আমরা এগুলোকেই বোঝাচ্ছি, মানে যেহেতু এই ধরনের সমস্যাগুলো রাত্রিকালে বেশি হয়।
কোমর ব্যথা কেন হয়?
কোমর ব্যথার বিষয়টা আসলে যে কোনো বয়সেই হতে পারে। সেটা
স্পাইনের আসলে কি কি ধরনের সমস্যা নিয়ে রোগীরা আপনাদের কাছে আসছেন?
প্রধানত যে বিষয়টা নিয়ে আসছেন স্পাইনে ব্যথা, স্পাইন নাড়ানো যায় না, মুভ করতে পারেন না।
লুপাস, এই রোগটি আসলে কোন ধরনের রোগ?
এই রোগটাকে আমরা অটোইমিউন ডিজিজ বলি।
একজন সাধারণ রোগী তিনি কখন বুঝবেন যে তার ঘাড়ের ব্যথা পেছনের কারণটা গুরুতর?
ঘাড়ের ব্যথার সাথে যদি কোনো রোগীর অবসতা বা দুর্বলতা, বোধ শক্তি কমে যাওয়া, অথবা প্রস্রাব আটকে যাওয়া, অথবা পায়খানার কোনো প্রবলেম।
ব্যতিক্রমী এই আয়োজনের মাধ্যমে সাধারণ জনগণ সহজেই রিউমাটোলজি চিকিৎসা সেবা নিতে পেরে প্রকাশ করেছে তাদের অনুভূতি।
আমি রিউমাটোলজি এই প্রোগ্রামটা প্রায় সময় দেখি, আমি উপকৃত হয়েছি। কারণ হচ্ছে এখানে আপনাদের নিয়মিত যে ডাক্তারগুলো বসে, সো ওদের কনসালটেশন যে অ্যাডভাইসগুলো, এগুলো আমাদের জন্য খুব ইউজফুল।
ঘাড়ে ব্যথা, কোমরে ব্যথাটা তার উপকার পাইছি।
আমার আম্মু একটু অসুস্থ থাকে, যেমন তার পায়ে ব্যথা বা পায়ের গোড়ালিতে বা ঘাড়ের ব্যথাটা খুব বেশি হয়, তো আমি এখানে ডাক্তাররা যে ধরনের টিপসগুলি দেয় উপকার পেয়েছি, উপকৃত হয়েছি।
ফ্রাইডে নাইট উইথ রিউমাটোলজিস্ট এই অনুষ্ঠানের মাধ্যমে আয়োজন করা হয়েছে ন্যাশনাল অ্যান্ড ইন্টারন্যাশনাল ওয়েবিনার।
Smoking cessation is very important. Balanced diet and nutrition, particularly containing flaxseed oil.
All the possibilities should be kept in mind in that situation.
Because in our daily practice, we have to encounter such a problem frequently.
22 জানুয়ারি 2021 সালে শুরু হয়ে ইতিমধ্যে 55তম পর্ব সম্পন্ন করেছে ফ্রাইডে নাইট উইথ রিউমাটোলজিস্ট। বাংলাদেশের ইতিহাসে প্রথম এই অনন্য আয়োজনটি নিয়ে মতামত জানিয়েছেন বাংলাদেশ রিউমাটোলজি সোসাইটির নেতৃবৃন্দ।
বাংলাদেশ রিউমাটোলজি সোসাইটি এর জন্মলগ্ন থেকেই নিরলসভাবে রিউমাটোলজি এই বিষয়টির প্রচার এবং প্রসারে অক্লান্ত পরিশ্রম করে যাচ্ছে। করোনাকালীন সময়ে রাজ টিভি প্রতি সপ্তাহে একটি করে প্রোগ্রামের আয়োজন করে জনসাধারণের সচেতনতা বাড়ানোর জন্য প্রতি শুক্রবার রাত 10টায় এই প্রোগ্রামেও আমাদের তরুণ প্রজন্মের রিউমাটোলজিস্টরা অংশগ্রহণ করে থাকেন।
ফ্রাইডে নাইট উইথ রিউমাটোলজিস্ট এটা হচ্ছে রিউমাটোলজি সোসাইটির একটা প্রোগ্রাম। আমি মনে করি যে এটা দর্শকদের জন্য একটা অত্যন্ত উপকারী একটা অনুষ্ঠান, কারণ এর মাধ্যমে আপনারা অনেক কিছু জানতে পারছেন, আপনাদের বাতরোগ সম্পর্কে কিভাবে চিকিৎসা করবেন, কিভাবে প্রতিকার করবেন এবং কিভাবে প্রতিরোধ করবেন।
বাংলাদেশ রিউমাটোলজি সোসাইটি আগামী 29 এবং 30 মে একটি আন্তর্জাতিক সম্মেলনের আয়োজন করেছে এবং এই সম্মেলনের প্রস্তুতি চলছে। সারা বাংলাদেশ থেকে 1000-এর মতো ডাক্তার এই সম্মেলনে অংশগ্রহণ করবে। এখানে এটি একটি সম্পূর্ণ বৈজ্ঞানিক সম্মেলন ঢাকা ইন্টারকন্টিনেন্টাল হোটেলে অনুষ্ঠিত হবে।
ফ্রাইডে নাইট রিউমাটোলজিস্ট অনুষ্ঠানটি সায়েন্টিফিক পার্টনার ডেল্টা ফার্মা লিমিটেড এবং মিডিয়া পার্টনার রাজ টিভি। সময়ের সাথে সাথে এগিয়ে যাচ্ছে বাংলাদেশ, এগিয়ে যাবে বাংলাদেশ।
আমার ল্যাপটপ দিয়ে করবো, তাই চলে আসি, আপনি স্ক্রিন অফ করেন।
তুমি কি ওয়াইড স্ক্রিনে করছিলে?
হ্যাঁ আমি তো স্যার ওয়াইড স্ক্রিনে করছি স্যার। এই যে স্যার আসতেছে মনে হচ্ছে। হ্যাঁ ঠিক আছে, ঠিক আছে স্যার, ঠিক আছে, সমস্যা হচ্ছে না। হ্যাঁ সমস্যা হচ্ছে, ঠিক আছে তো, মানে স্ক্রিনে স্লাইড তো হবে না। আচ্ছা ক্লোজ করে দেন, ওপেন করে
এটা দিয়ে দিব। আমি দিয়ে রাখতেছি আপনাকে, শুধু আপনাকে যখন নাম দিয়ে দেবে তখন আমি স্ক্রিনে দিয়ে দিব। হ্যাঁ এটা আমি এখন ওপেন করে রাখি, এটা এখন আমি ওপেন করে রাখি।
Ladies and gentlemen, Assalamu alaikum. I'm going to start our first session. In this session, we have two speakers, Dr. Farjana Shumi and Professor Dr. Muhammad Badrul Islam. This program session will be chaired by Professor Ghulam Kibriya and moderated by Dr. A.K. Ahmedullah. Now, I'd like to request Professor Ghulam Kibriya sir and Dr. A.K. Ahmedullah, please come up on dais and moderate the session. Sir, আপনি ওখানে চলে যান। আমি আপনার নাম
Assalamu alaikum. Good morning. dear participants, you have already heard the name of our speakers and chairperson. Our chairperson, Professor Dr. Muhammad Ghulam Kibriya, is already on the dais. Our first speaker is Dr. Farjana Shumi. From BCS in 2013, MRCP in 2016, and MD Rheumatology in 2019. She has got 27 publications in different national and international medical journals. Her research of interest is vasculitis, musculoskeletal ultrasonography, and also on capillaroscopy. She is currently working as consultant rheumatology in Square Hospital, Dhaka. Now, I like to request Dr. Farjana to deliver her speech. Dr. Farjana Shumi, please.
Thank you, sir. And first of all, I'd like to express my gratitude to Bangladesh Rheumatology Society for giving me this opportunity to talk in front of all of you, my teachers, respected professor, and learned audience. So I'm sharing the same stage with my teachers. So I'm really afraid of it. So I think that do some meditations and next 25 minutes, it will really help me. So why vasculitis is interesting? It still derives intellectual challenges for physicians. And I would like to start with historical perspective on vasculitis because all discoveries can be the starting point for new research. And the history started actually in 1815 when Professor Hunter in London first to recognize the inflammation of vein and first to recognize the muscularity of the artery. And he described several cases in this book. And then the interest was growing rapidly, and in 1815, Professor Hudson in London first described non-syphilitic inflammation of the artery. He described a clinical case who was returned from Jamaica, suffered from fever and pneumonia, and later postmortem was done and found inflammation of the artery. And 1852, first Professor Karl Rockit and Sky describe these aneurysmal dilatations of a patient who died due to fever, abdominal pain, and postmortem was done later. And 1887, his student Epipenger first depicted the histopathological pictures after doing the re-postmortem, and here the inflammatory cells invading all the layer of the vessels. And first of all, the most important thing about polyarteritis nodosa in 1866, Professor Kushmol, who was also known as grandfather of vasculitis, and Professor Mayer, pathologist, and he sketched the heart of a patient of polyarteritis nodosa who died in the hospital suffering from fever, abdominal pain, and severe myalgia. At first report, they wrote that the case as a periarteritis nodosa, and it was thought to be due to worm infestation. But when the second case got admitted, he wrote it as a case of polyarteritis nodosa. And in 19th February, suggested the more appropriate name polyarteritis nodosa because more and more cases were coming. And in 1908, Dixon confirmed the observation by depicting the microscopic examination of mesenteric artery aneurysm. If we look carefully, in 1922, Eville described that there is another distinct form of polyarteritis nodosa, which is only visible in microscopic examination, not in macroscopic examination. And then they divided classic pan and macroscopic polyangiitis nodosa, which is later adopted in 1994 in Chapel Hill Consensus Conference nomenclature. And several other vasculitis were coming from different parts of the world at the time. So let's discuss about the classification of vasculitis. It's very important because we have to start early treatment in several forms of vasculitis like ANCA-associated vasculitis. Antiviral treatment is needed for hepatitis B virus associated PAN. And if the vasculitis is limited to the skin, we should avoid unnecessary use of cytotoxic drug. In 1952, Cheek proposed a generic term first, just careful that first he proposed a generic term necrotizing vasculitis, and he divided the vasculitis into 5 subtypes. And Professor Fawcett later described 7 groups of vasculitis, and the classification was increasing. And in 2005, First, he described that vasculitis could be secondary. In 1990, ACR classification criteria came and they divide vasculitis into 7 groups. And they didn't include MPA, but they include hypersensitive vasculitis because there are similar clinical features and the differentiation was made only by histopathological examination. And in 1994, in Chapel Hill in USA, there was a conference and nomenclature came at the time. And in this nomenclature, acute microscopic polyangiitis, which was not included in 1990 ACR classification criteria. They replaced hypersensitive vasculitis in cutaneous leukocytoclastic angiitis because the clinical features is only limited to the skin without any systemic vasculitis or glomerulonephritis. And this is the old nomenclature in 1994. You can see the name Wegener's Charget-Strauss disease. But 20 years later, in 2012, there was another conference and the nomenclature was revised. And at the time, the branches and analogous vein and medium vessels are visceral arteries. And until it retains its muscular coat, and small vessels are intraparenchymal arterioles, capillary, venous, and vein. And here you can see that there is significant overlap between the vasculitis. Large and medium vessel can involve all type of artery, all the size of the artery, and small vessel vasculitis involve medium-sized artery. And they divided small vasculitis into 2 groups, immune complex and small vessel vasculitis and ANCA-associated vasculitis. And they also included various types of vasculitis like variable, single organ vasculitis, vasculitis associated with systemic disease, and vasculitis associated with probable etiology in this nomenclature. And there are several articles coming nowadays regarding ANCA-associated vasculitis. Some authors would like to divide ANCA-associated vasculitis into 2 forms like granulomatous and vasculitic features according to prognostic criteria. And another author would like to divide into anti-proteinase 3 associated vasculitis or anti-MP ANCA-associated vasculitis. And there are some clinical trials also conducted by dividing the ANCA-associated vasculitis into 2 groups. But nowadays, ACR Euler study to develop classification criteria for vasculitis. This already did some studies, and the drafted criteria already came regarding giant cell arteritis. Halosign included in the drafted criteria. In Takaisho arteritis, age has been increased to 60 years, and there are some weighted scores according to number of the arteries and symmetrical involvement of the paired arteries. And the classification criteria on MPA has already been published on eGPA, and on GPA has already been published by Decivas. Regarding immunopathogenesis, you can see here that the normal architecture of the vessel, the clear lumen, but when there is vasculitis, infiltration of the inflammatory cells causes occlusion and produce 2 clinical outcomes like occlusion of the lumen and destruction, sometimes destruction of the artery wall produces aneurysm formation. And there is another immunopathogenesis according to hypersensitivity reaction described by Kunz and Gels. So let's move to the most important part, the diagnostic approach of vasculitis. First of all, we have to suspect vasculitis. So when should we suspect? If patients develop non-specific symptoms such as malaise, weight loss, fever, and night sweat, if patients have unexplained ischemia, and this is especially in the presence of systemic inflammatory response or features, purpura, myelinomatous multiplex, or glomerulonephritis. In a nutshell, if patients has had multi-system involvement. And how can I recognize the clinical features of vasculitis? If there is involvement of the small vessels like cutaneous and postcapillary venous, palpable purpura, hematuria, and pulmonary capillaries produce hemorrhage, lung hemorrhage. If there is involvement of the medium artery like cutaneous artery, patient produce ulcer, mesenteric artery, abdominal pain, branch of the celiac artery, infarction of the liver, coronary artery, MI, and small pulmonary artery produce necrotic lesions and nodule. And large vessel involvement, like extracranial branches of the carotid artery, produce headache, and thoracic aortic branches can produce lymph claudications. And second step is very important because we have to be very careful about excluding the mimickers and secondary cause of vasculitis. There are several mimickers of large vessel vasculitis. All of you know that infectious causes, like in acute infection, sometimes there is formation of mycotic aneurysm with septicemia or endocarditis. In chronic infection, tuberculosis is very important for our country because our country is endemic for tuberculosis. Sometimes cause invade the artery wall and produce aneurysm. And there is atherosclerosis, also great mimic. There are some congenital cause like aortic coarctations and middle aortic syndrome. And there are other mimics as well, IgG4-related disease, when there is head and neck involvement. And fibromuscular dysplasia, there are two forms, like sometimes it produces stenosis by involving intimal involvement, and sometimes there is aneurysm formations by involving the media of the vessels. And segmental arterial medullosis, which is very uncommon, but sometimes you can face this, and this is very important mimic. And there is a list of genetic syndrome. I'm not going into detail because there is constraint of time. And these patients, I'd like to share the mimics of large vessel vasculitis presented with claudication. So naturally, we thought about that large vessel vasculitis, but later she developed libido reticulosis type of rash and deep venous thrombosis. Her APS panel became positive, and MRA showed wall thickening, resulting in complete occlusion of the second part of the subclavian artery without any thrombus. So the diagnosis was made antiphospholipid antibody syndrome presented with claudication. So mimics of medium vessel vasculitis, this is a big list. Just I would like to mention some important cause: virus-associated vasculitis, hepatitis B, HIV virus, atherosclerosis, malignancy, lymphoma and leukemia sometimes cause gangrene and mimic medium vessel vasculitis, and there are some fibromuscular dysplasia, as I mentioned, hypercoagulable status like TTP and APS. And there are other comparison of conditions that may be medium vessel vasculitis, as I mentioned, segmental arterial medullosis, which is very uncommon, mainly involve the visceral mesenteric artery, fibromuscular dysplasia involve renal artery, and polyarteritis nodosa involve mainly intra-abdominal arteries, and Kawasaki as is involve coronary artery. And infected endocarditis can involve any arteries and produce severe aneurysm. So in recent era, there is several reports, several publications regarding DADA2 deficiency. So it's a rare autosomal recessive autoinflammatory disease. We should suspect in children and young adults if patients presented with pan-like vasculitis. And this slide showing the clinical features of DADA2 deficiency, more or less similar to polyarteritis nodosa. You can see here libido racimosa, nodule, purpura, articular rash, gangrene, various CNS features, musculoskeletal features, all are similar to polyarteritis nodosa. And this diagram is showing basal ganglia infarction, renal artery infarction, cerebral aneurysm and occlusion, which is found in DADA2 deficiency, and subcutaneous nodule, libido reticularis type of rash, subcutaneous nodule, and maculopapular rash in DADA2 deficiency. So what are the mimics of small vessel vasculitis? When this is the mimics, the cholesterol microembolism, APS sometimes mimic small vessel vasculitis, solar purpura can mimic if presented with cutaneous vasculitis, and purpura due to thrombocytopenia, livedoid vasculopathy, which is a great mimic, and septic vasculitis, and purpura fulminans due to DIC or sepsis. So this is a big list of mimickers of small vessel vasculitis. I'm not going into detail. And this lady, I'm just going to describe how difficult to exclude the mimics of vasculitis present with chronic leg ulcer. Several times biopsy was done and livid features of small vessel vasculitis, and later biopsy revealed the features of livedoid vasculopathy treated with suppressive drug, anticoagulant, aspirin, as described in treatment of livedoid vasculopathy, but later she received immunoglobulin levels, and this is her recent status. Livedoid vasculopathy is sometimes, some words regarding livedoid vasculopathy is very difficult to differentiate and recognize because in biopsy sometimes there are inflammatory cell infiltration occurs. And the previous report, previous era, livedoid vasculopathy, also known as livedoid vasculitis, and there are several other names of livedoid vasculopathy. And let's fourth step, we have to see the extent of vasculitis, because if there is internal organ involvement, the treatment is different. But if there is isolated cutaneous vasculitis or limited vasculitis, like in limited GPA, the treatment protocol is different. And fifth step, we have to investigate the patients. So commonly measured tests, which are commonly measured tests like raised yes sir and CRP, found in polymyalgia rheumatica and GCA. If you get eosinophilia, can sustain eGPA. Leukocytosis and thrombocytosis commonly found in GPA, but as well as in MPA and sometimes in polyarteritis nodosa. Urinary sediment we will find in ANCA-associated vasculitis, but remember that urine sediment will never get in polyarteritis nodosa. But raised creatinine could be found in ANCA-associated vasculitis and polyarteritis nodosa as well. So we have to mimic this and disclose the secondary cause. If appropriate clinical features, we have to do blood cultures. Echo and sometimes transesophageal echo is also needed to exclude infective endocarditis. Regarding viral serology, there is a big list: cytomegalovirus, Epstein-Barr virus, which all cause, and herpes simplex virus, vasculitis, and vasculitis-like features. HIV, ANA test, we should exclude secondary cause. APA, antiphospholipid antibody panel, rheumatoid factor, anti-CCP, and serum protein electrophoresis. Because in well-described macroglobin, sometimes you get digital gangrene, and also monoclonal gammopathy usually associated with cryogenic vasculitis. And then we have to assess the extent of vasculitis by doing urine routine microscopic examination and chest for all patients. But NCS, EMG, especially if the patient has had clinical features or sign, and CPK and small and medium vessel vasculitis. So to confirm the diagnosis, how we'll proceed, we can do biopsy, we can do angiogram. And to identify the specific type of vasculitis, we have to do ANCA. Regarding ANCA, the recent recommendation is to do ELISA to specify antiproteinase-free and anti-MPO. But if you have high suspicions and ELISA became negative, you can do immunofluorescence. And we can do cryoglobulin levels and complement levels. Regarding complement levels, remember that in ANCA-associated vasculitis, complement levels will be never low, it will be normal. But low C4 could be found in cryoglobulin vasculitis. Eosinophil count could be high in Stargardt disease, and then we have to clarify the specific findings in biopsy. And there are several autoantibodies are coming in the literature, and Professor Debashish Tanda sir nicely described these autoantibodies and biomarker. Anti-C1q antibody found in hypersensitive arterial vasculitis, which is already described, but it is also found in Behçet's disease with vascular involvement, like rheumatoid factor and ANCA in ANCA-associated vasculitis. The researchers scientists do the level of rheumatoid factor in ANCA-associated vasculitis, and they found there are high levels and indicate increased activity. But regarding ACP, the small percentage is very low. And anti-endothelial antibodies found in vasculitis as well as Behçet's disease, and antiphospholipid antibodies, and anti-nuclear antibody, anti-plasminogen, anti-ferritin, and anti-laminin. So there were several studies are coming, like identification of novel serological autoantibodies in Dhaka arthritis patients. So I'm not going into detail of that. So several blood biomarkers are also coming, like IL-6 levels, serum amyloid A, and pentazine 3. Sir has already described that importance of pentazine 3 regarding assessment of disease activity of Dhaka arthritis, and serum amyloid A is also found in giant cell arthritis as well as Dhaka arthritis, and IL level is also very important. So there are other biomarkers in large vessel vasculitis like endothelial progenitor cell, circulating correlated well with active disease. Antibody against ferritin have been reported in patients with new onset GCA. And biomarkers in small vessel vasculitis described like in ANCA-associated vasculitis, CXCL3, MP, matrix metalloproteinase. Several circulating cryoglobulin levels also depicted as a biomarker. In IG vasculitis, 13 and Kawasaki NT-proBNP. The next step, we have to do biopsy, especially in small and medium vessel vasculitis, to confirm the diagnosis. Commonly favors serous skin, kidney, temporal artery, muscle, nasal mucosa, which is for polyarteritis nodosa. And choice of biopsy site is between skin and patients are involved in muscle biopsy, because presence of necrotizing glomerulonephritis not only help us to confirm the diagnosis, but also help us to delimit the next clinical treatment protocol of the patients. And regarding some words regarding biopsy, like blind biopsy to exclude vasculitis with non-specific generalized symptoms are usually not helpful. In slender biopsy, the percentage only sensitivity is only 45%, and necrotizing granuloma are not always found in nasal mucosa or lung biopsy specimen for patients with suspected GPA. So these are the findings you should look in biopsy in histopathological report, like presence of giant cells, presence of fibrinoid necrosis, presence of eosinophil, granulocytes, and leukocytoclasia. So if the patient has granuloma, there are possibilities of Dhaka arteritis, GCA, GPA, and eGPA. But if there is infiltration of mononuclear cell, possibilities is large vessel vasculitis, necrotizing granulomatous and neutrophilic. Possibility is GPA, necrotizing granulomatous and eosinophilic, eGPA, necrotizing and fibrinoid necrosis found in polyarteritis nodosa, and necrotizing vasculitis affecting small to medium middle artery, mainly found in microscopic polyangiitis. And immunofluorescence is also important. If we get no immune complex, this is post-immune, particularly ANCA-associated vasculitis. If we'll get IgM, this is type 2 or type 3 cryoglobulin. And rheumatoid vasculitis, if you'll get IDA, this is henoxylin purpura, and if you will get IgG, complement and fibrin, this is hypocomplementary vasculitis. Regarding imaging, there are several imaging modalities like conventional angiogram, CT angiogram, MRA, MRP, MRI, and ultrasound and PET CT. And this is conventional angiogram, which was used in the classification criteria in 1990 in this year. But recent recommendation is the Unwashed angiogram is not recommended for the diagnosis of GC or Dhaka issue. MRI is investigation of choice to investigate the mural inflammations and luminal changes, because these luminal changes and mural inflammation only be depicted in MRA, magnetic resonance angiogram. So we can do PET CT, is an alternative test, and ultrasound also limited value because it cannot depict the thoracic aorta. But ultrasound has value in depicting halo sign in giant cell arteritis. And the sixth step and the final step is that we have to specify the type of vasculitis. How can we specify the type of vasculitis? If you look carefully, there are several differentiating features in between giant cell and Dhaka arteritis. In Dhaka arteritis, temporal arteries may be affected, but axillary arteries commonly affect involving giant cell arteritis. In giant cell arteritis, the involved vessels is bilateral or vessel involvement in most patients, but in Takashi it is less symmetrical, and most often it involves left subclavian common capillary artery. And in Takashi there are more frequent relapse and greater need for surgical intervention, but in giant cell arteritis there is less frequent chance of relapse. And the small vessel. So glomerulonephritis is more common, but in PAN, there is renovascular involvement like hypertension, raised creatinine. In M, capillaritis is more common, patient present with lung hemorrhage, but in and usually anti-MU. Are more reason of involvement in between the three ANCA-associated vasculitis, which is that double positive. That means found that blood should also found dog before they presented or developed features of good journey picture is a very current journey. We have to assess this activity, we have to assess the damage, we have to assess the quality of life. Written this activity are sales schools and we are very happy that our country, Indian Dhaka activity school, Kolkata ultrasound school. And this is my last slide. I would like to conclude by giving some take-home messages like overlap in vasculitis is careful exclusion is necessary. Importance of engaging in diagnosis of various vasculitis, new autoantibodies and biomarkers are developing. Histopathology immunosense is a key to diagnose multiple vasculitis. Then we should be very careful regarding assessing disease activity and damage. This is very necessary for appropriate management of the patient. With all this, I would like to conclude and give thank you by sharing this wonderful of Dhaka. Thank you. Well,
Thank you. Beautiful question. Now, may I Islam today's speech. I could introduce briefly. Nurul Islam University. He has 105 publications in different international peer-reviewed journals and journals. He himself is a reviewer of several journals. He is the Secretary General of Associate Editor of IRD, Associate Editor of the Journal, founder member and Vice President of Bangladesh Rheumatology Society, and he is also serving as in different organizations in different posts, and also in research and health education programs. I Professor Muhammad Nurul Islam.
Ladies and gentlemen, practice. A single presentation, patient with the or gangrene and in the ocean. How to solve the case? So I will try to share with you our experience, our study in this regard. The first problem is or challenge how many face by the vasculitis, competition and health. What are the type of problem? These are the hormone system disease syndrome and easily rheumatoid arthritis, polyarthritis, dandruff. I have echo prevalence hormone sclerosis. Embolism, forget trauma related vasculitis. That is a big list. This one, that is obliterance, Alzheimer's syndrome, the malignancy, drugs are with this starting of the thoracic syndrome, hemophilia, infection disease, and hepatosome. And the it is to put okay. It's time for it's good to put let's go. So bhai is essential yes this blood and both immune got on this and we don't know the cause. How to differentiate between vasculitis? Some is here to start in vasculopathy is the system. It is with the like vasculopathy in mark is the process what is thrombus and cold usually it's a in case up but is more case helps us to figure out how is one audible happening with is one state is good. You can if we approach case things sectional visibility go down and the final and from surgery prop so present. So the of the causes, as there are many causes behind. I'm to slide click. So how can? Here is the conceptual framework for this one. Digital ischemia. So thromboembolism. In next slide I have mentioned one is the and next to this and already the name volume. Then we about the doctor is identified history and tragedy that is problem. And multiple side no soft artery absent the corridors mitral patient is the thrombosis is multiple essentially as an and embolus in the case. The hypertrophy both pathology and practice their needs starting from the antibodies from the pathological disorder including age also immobilization might trigger and patient level. The art of digital evaluation number of history should be non-biased. Biased you will he or he able to reach to the proclamation is to difference and difference need to become because our if what would be diagnosis this is where in terms of hospital presented like of the gives to and is last many features are vertical. The black this is the business and we it. So you have vasculopathy group. This is to get here to tell crash in the pressures. very up and lower fingers and toes. Material is a 30-year-old is beginning by fingers. He gives polyalgia fever for last month. So what from CTO, what would the gangrene is there, is there, but the everybody know the is stimulus. No, at least we child access sleep and test the test of single is phenomena and happy in the cell. So this group. And if we look at this figure, it's a and he was a features of fatal disease known for those who are small are safe from disease and dystonia. We miss one. So here we can have clock. Can be 6 P's and help us to understand case of different. The type of pics in the what could be an issue or diagnosis a smoker the left foot and the great to give history of the medication. The commonest are normal. So what are the differences? It's to be tablet. Looking his and if we need to bring our study what bring up can be the case 1 years old student the left foot and fifth finger 4 months on the basis of the ulcer the exercise market and unrecordable on the and left side. So what is this? Is a have the we check case number in our word that I think in our practice. The information and Dr. Bidhan he find out that that is this practical and clinical and a little paper published down the globe paper and in the find out the calculation aim to be studied the etiology overview for the introduction of this study is because these are the common diseases, rheumatic diseases related to the higher percentage of prevalence of digital ischemia in clinical practice. And the other common diseases are little, starting from what are the causes mentioned, they are often related. Peripheral artery is the other disease most common. It is a common 22% of and their prevalence is much lower than that of the other common rheumatic diseases. So we have did this study in our center. 25 consecutive cases able to enroll in our study, and all cases been requested with the group. And here we have described should criteria, and here is the that mean subscribe age was 22 years, and for with the the important observation from our the one disease, the 4% price in one. The osteopathy, these can are our study in a distinguish between these stages. Here, they significantly higher the vasculitis group than that of the vasculopathy group. In our study, the striking observation is that we got 4 cases, 3 men and the 1 woman. 2 men are less than 40 years of age. So once I have talked with the risk factors, there I have mentioned more than one in the and female tend to include is they have done. I hope the limitations to other good enough to that study. The conclusion vasculitis lupus was the cause of what is the emergency multiple factor careful condition due to and several classification help in quick assessment of disease should be grouped into if there I don't want the I wish for my hand let for
presentation. Sometimes sitting. It's a help. Now, I invite person
Yeah, Assalamu alaikum. First of all, thanks to the organizer, the Society, President, Professor Professor Naturi, Abu Shahin, Chairperson of the Registration of School, President Dr. Shumrat. Thanks to moderator for the first to me, President Lecture, Vasculitis, elaborate history, clinical fear, prevention of vasculitis from persistent kidneys, systemic manifest, and diagnostic criteria, diagnosis and management excellently. Thanks the further Swift is excellent to the classroom again for his excellent. The 10th speaker, Professor will know to use him as a speaker. He is a expert. He has made the vasculopathy digital the prevention of peripheral vascular disease and this presentation our place, especially young future. And thanks to Islam for his extreme presentation. And thanks to the speakers. Our moment, our and so next Professor Mohammad Nazrul Islam, sir.
and then she has gone to USA and has a residency training in internal medicine in USA, and also training in rheumatology also from USA. And she has some postgraduate degrees, that is Diploma at American Board of Internal Medicine in 1988, Diploma at American Board of Rheumatology in 1998, and it was recently in 2008 and 2019. And she is working as a professor and associate dean in the Institute of National Hospital and Medical Center, Chair Faculty, University of Health Sciences, Adjunct Faculty at Medical University. And she is also member of APLA, member of Pakistan Society of Rheumatology Council, Master of American College of Rheumatology. She is the pioneer in developing the first training program in rheumatology recognized by College of Physicians and Surgeons at Pakistan. And she has also developed postgraduate programs while serving an associate dean in postgraduate training program in Fatma FMH College and Medicine and Dentistry. She was given several awards. Firstly, the awards of excellence by His Excellency Governor of Punjab in recognition of her invaluable contribution during COVID pandemic. In 2021, she was awarded Master of American College of Rheumatology Award in 2019, and she was awarded Award of Excellence from Pakistan Society of Rheumatology in 2017 for outstanding contribution.
That our region, Professor Tanda. It's a pleasure and honor to be here to be delivering this talk. It's a clinical talk, and I know it's more geared to the socio-economic situation in our country, where we deal with clinical scenarios which are very challenging. So let me, can you see my screen? Wait.
Yes.
Sorry, can you hear me? I have a feeling that there's a problem with the sound. Is everybody can hear me?
Madam, we can hear you.
Okay, great. Thank you so much. This is my journey, starting from my alma mater in Lahore to my training at Metro and Cleveland Clinic, where I happen to have some experience with Gary Hoffman, and that developed my interest in vasculitis, and that is my clinical interest, and I love to talk about vasculitis. I know that the leaders over here considerably well ahead in our region, India, Pakistan. Sorry, had a problem. This was my first meet with Professor Dana, and I wish Professor Dana, we had leaders, more leaders like you in our region. Minhaj is sitting there, and I can see Nazrul is sitting there, and I was wanting to be there with you. I first visited Bangladesh 7 years ago for a speaker in a conference. There has been absolutely no going back, and the connections which we have made. Let me quickly go over my talk. This is a young boy, and cannot forget it. What happened to him? Lost all his 4 limbs, was in a teaching hospital, but unfortunately, because of lack of awareness of this subject, I don't think anybody would have willfully neglected their duty, but it is because of lack of education in rheumatology, as well as especially vasculitis. So we know that at least if we cannot treat, we should not forget this quote. So hence my objective today will be, how can this disease present? How can you differentiate between different types, and how to manage them according to evidence-based, and how to maintain that remission, how to manage refractory relapse according to the latest guidelines. So let's start with a very interesting. We've all seen such cases: recurrent chest infections for 8 months, 50-year-old male, ear pain with discharge, and basically going from doctor to doctor and going everywhere, getting several courses of IV antibiotics, oral antibiotics, but ultimately he had a bout of disease, and he was shifted to the hospital. He was complaining of shortness of breath, he was tachypneic, he was tachycardic, he had bilateral fractures on his chest, he had non-blatching rash on his legs. He was shifted to ICU on 5 liters of O2. His first test which comes back from our lab is hemoglobin of 7, WBC is 12,000, creatinine of 2 milligrams with active urinary sediment, and a PC ratio of 2 grams. Immediately an X-ray and CT chest was ordered, blood cultures were done, cultures all of medical flow calls the most with the pulmonary hemorrhage, with hemoglobin going down and hemoptysis, does he have anti-GM disease, or he has so many others which are in the differential. So this was the question. Should I immediately give IV methylprednisolone? Should I wait for cultures? And of course, the question always is, do we wait for antibody tests? All this takes time. We are a developing country. We don't have the resource. And who will wait for the results of biopsy? So the question is, are we going to treat, or are we going to wait? So no, the senior ordered to give IV methylprednisolone immediately, 1000 milligram, is already cultured, IV antibiotics. The question was, does he have pulmonary renal syndrome, which is caused by ANCA-associated vasculitis, or does he have SLE, or anticoagulation basement disease? And But whatever these are, these empiric high-dose corticosteroids are almost most appropriate since disease can progress rapidly. So you can't wait for test results. Our CT technician is somewhere far away. This is in the beginning of establishing the institutes, which we have done now, but for him to come and do a CT scan for us waiting is not great. So we were all suspecting vasculitis. A lot has said about vasculitis, but we should know that blood vessels is occluded because of inflammation in the vessel wall and the injury which is caused by segmental necrosis and occlusion of the vessel by the clot and fibrin occlusion. So there have been so many attempts of classifying vasculitis. We need to know, starting from Chapel Hill classification to so many of them, but for us clinicians, I find that this works well. Aorta and Esperantis, giant cell, Dhaka and Scoop has done so much on it. Large size to medium size. I'm going to talk about this. Look at the small vessels. So when we are looking at small vessels, we are looking at two groups. One is microscopic polyangiitis and others. And differential is with anti-basement, glomerular basement disease. But we must remember that we have to occlude the mimics. Anchors, I'm not going to talk about is antibodies which are directed against neutrophil cytoplasmic proteins. DR3 anchor, which is usually associated with GPA, but may be present in about 10 to 20% of patients with MPA, and anchors which are directed to MPO, and ELISA method of determining them is very important, and they may fluctuate over the course of disease. Quickly, what is happening? There's an activated B cells. It is stimulating the plasma cell, and the plasma cell is releasing anchors that are released through the bloodstream. And when it is released through the bloodstream, what happens is that we still don't know. Is it infection, exposure to environmental stimuli? Is it genetic? What is it which causes this trigger so that anchors are bound to the antigens on the neutrophil, and that leads to a cascade, reactive oxygen species, proteolytic enzyme, and they activate the alternative complement, and so this ultimately leads to destruction of the vessel wall, and which is the hallmark. Necrosis is the hallmark, especially of GPA, and destruction of the tissues. So you can see what happens to this vessel wall, which can give the vessel in the lung, in this case, capillaritis, and obviously there comes the hemorrhage. So this actually is the so how I think the latest classification of ACR ULAR, which is not in print as yet, but it is available on ACR Convergence, but it's not published as yet. And they know that things have changed, and we need, for the management of these diseases, we need to know the criteria. Criteria are usually used for research. They can only help clinicians. Clinician judgment is the best. So for GPA, remember, read GPA, remember. This is published, not published, but this was in the ACR Convergence. Remember that the most important clinical criteria is upper way involvement, cartilaginous involvement, or hearing loss. And the most important lab test is positive P3 anchor. For microscopic polyangiitis, we are in this patient who we say that he had MPA. The most important clinical criteria is absence of upper way involvement, and most important lab criteria is MPO anchor. And the most dominant criteria which will exclude this disease is absence of PR3 anchor and eosinophilia. I think if you remember these basic rules, and similarly, the most important clinical criteria for EGPA is obstructive disease, asthma, nasal polyps, and neuropathy. And the presence of eosinophilia is the most important lab criterion. The presence of PR3, if present, should push the clinician away from classifying this as EGPA. Again, these are guidelines, and these are not something to be followed strictly, because in our patient we don't have anything of this sort. We only have a clinical situation in front of us. Does our patient have GPA? This is an excellent document which is published with, please go over it. We have references when this is for GPA. I think it is an excellent document. The way, first of all, we rule out mimics. And can you imagine that in GPA, the clinical criteria which is most important is nasal involvement, bloody discharge, ulcer, crusting, congestion, blockade, septal defect. Cartilaginous involvement of the nose gets the score of 2 and it was 1. So far, I need 1 score. And then how much important this involvement, he another 2, so we have 3. We do not have his kidney biopsy, but we think that his kidney is involved. It's always possible to, we don't have the resources. And similarly, the conditions which mimic vasculitis, you should all know the most important thing which will microscopic. If you have patient, you will exclude patient. Account is greater than 1,000, then it's become -4. So see, as I said, we should be very and similarly with EGPA, the most important thing I think to here, the differentiation between two is that is more seen in EGPA. Mortality in that condition and neuropathy more often than the conditions, and most of the things which we have here, we see that are lapping, but we see that ENT involvement in MPA is not seen, eye involvement is not seen, and rest is pretty much common in most of them. So here is a 45-year-old male, female with 2 years history of facial pain, nasal congestion, epistaxis, she's seen by ENT, always go to ENT. They will always go to ENT. So they immediately biopsy of nasal mucosa, and they also referred back to rheumatology and couldn't come back quickly. She had population and central nose deformity. Meanwhile, pulmonology done everything, and the question is, nasal mucosal biopsy, or you will do set P3 anchor, or do you want to set anti-row, detection of antibodies to MPO? We already said if you offer nasal involvement, you will not send MPO. The most correct answer is antibodies to PR3. Sjogren can also cause progression of nasal dryness, but it's not severe. Biopsy is never a choice for diagnostic. Biopsies, while we can have sometimes in the range of 70%, so we can have P and negative patients also. Then you get the biopsy. So let's see. We have a challenge when there's already nodules, but most of the time, if you look at this clinical scenario, that we have to go clinically because our patients cannot afford it. Now, this is the background or clinical spectrum, some important things, references there, go back and go over that. UVAS, disease categorization, and actually I borrowed this from the chapter, Danda, and this is the Handbook of Biologics, Niraj Jain and Lalit the Galata editors. So this is a good way of managing. We need to know whether this is systemic, whether this is generalized, but creatinine is less than 5.65, but severe when they are renal, creatinine greater than 5.65, vital organ failure, because aggressively we need the patient where does basically which category the patient is. So, okay, let's. So there have been several trials. I'm not going to go over there. There is references. There are a lot of references given, and I think the land since 19. A lot has been done, and where it was like a death sentence for diagnosis of vasculitis, the mortality, morbidity is. I think most important trial which I'm going to talk about a little bit. This is when rituximab came in. This is cytoxin, and then this was what we thought about rave trials. And one must go over them. They're very interesting. We focus on induction, repetition, and because should we give for maintenance? Generally speaking, after most of the practices are different, but I think this was a good review. Evocupan for the treatment of ANCA-associated vasculitis, is it available? This is by David Chain and Peter Merkel. This trial was involving patients with ANCA-associated vasculitis. Evocupan was non-inferior but not superior to prednisone taper with respect to remission at week 26 and was superior to prednisone taper with respect to sustained remission at week 52. So patients also received cyclophosphamide and rituximab. I think this is all we have references. Recent ACR guidelines, which was published very recently with key treatment recommendations for the treatment of GPA. Actually, remember, I think we need not go on to details of this, but remember the principal thing that if you have active severe GPA like the one which we did, remission induction, rituximab is actually favored over cytoxin and reduced dose GC over standard doses. So after you giving IV pulse for 3 days and a week of high dose steroids, you immediately start cutting back. So if you reduce the remission, then obviously again the maintenance of remission is preferred over MMF for countries like us. It's a big challenge, and we manage this. But if remission is not induced, if you use rituximab for remission induction and vice versa. But if it is the second patient, it's not severe GPA, which you're seeing on the right-hand side, they recommend induction with glucocorticoids, and you only use artificial develop elevated enzyme, could not use the for this patient with nasal perforation, and she had allergic reaction to rituximab. She had not tolerate MMF, and we are back to cytoxin, and she's on cytoxin now. If remission will be induced, obviously we'll go to the either the same which cytoxin in our case, or maybe Lifura, or maybe try other options. But if it is not achieved, then you will go to the other options. But how do you maintain once you have maintained remission, or how do you manage relapse? Very nicely written here. But for our patient, we have to monitor whether the patient has relapse. If there's no relapse, we will continue with the rituximab, and it's like fixed dose every 6 months, or there are different regimens, or sometimes there's a trial going on which looks at how well the rituximab given according to the cell returning back works in comparison to fixed dose, and it's the same. So I think for our countries, we can't keep on ordering tests. I think if we have somebody in remission, we should give it in a fixed dose. Similarly, if in remission is not induced, then you have to switch to a different agent. But for our non-severe GPA patient, hopefully she will induce remission with cytoxan, and we don't have to give her cytoxan for a longer time. And if her enzymes return to normal, we'll choose either methotrexate or Lumine. So this is something to continue, and we have recommendations for others also. But I think it will be best that if we go back and look at those details, which are the latest. The effects of plasma exchange is a great debate. There's a lot of literature. Let me quickly tell you what is the meta-analysis, because we are dealing with clinical situations here. This was recent detailed data for randomized control trials examining the effects of plasma exchange on outcomes in patients with. What was the conclusion? It found that plasma exchange, when added to standard therapy, reduced the risk of end-stage kidney disease at 1 year, regardless of baseline kidney function, but it increased the risk of serious infections. And this was a previously unrecognized effect of plasma exchange, and this plasma exchange not affect mortality. An important thing. I would. This is a busy slide, but I would recommend all of you to read this very nice paper written by and it's in print already. The latest article, plasma exchange and glucocorticoid dosing, and again they recommend very low glucocorticoid dose. This study reviewed almost evidence from 9 randomized trials with 1,000 patients, and the recommendations for PLEX were only for patients with high risk of end-stage renal disease. If their creatinine is greater than 5.8 milligram%, then, but less than that, the advantage was not significant, and there was high risk of infections, and that was a concern with PLEX. So if patient is presenting with only pulmonary hemorrhage, you will give PLEX only if there is hypoxia and patient is not responding, and lowest possible dose. This is the crux of this paper. There are more coming in and more of them, and I would suggest that you go over them. We will leave mepolizumab. It's not available here for EGPA. EGPA is very tricky because if it's antibody negative, it does not respond to rituximab that much as to cytoxan, and the cardiac events people are scared of. The most important thing is educate your patient, record any new symptoms, make sure your infection risk is and monitor their VAS. Okay, we do it in the clinic. We know Dr. Danda and this group has done so much for the Dhaka monitoring, and I'm really proud of that work. Titers, are we going to follow that? Are we following them? Well, I think I love this, because if clinically you think that the patient has a flare already, 20% your pre-test probability you're thinking, then and if the ANCA rises is 42%, then there is a chance that the patient is flare. But if no rise in ANCA, there's only 10% chance, so don't just jump to ANCA titers. On the other hand, look at the last column. If clinically you're suspecting there is a flare, then rise in ANCA also, then you will have a 92% chance of having a flare. But if there's no rise in ANCA, the chance is there, but less. So I think this was an important message here. Make sure you have vaccinated these people. They are on Cepton, looking at osteoporosis, vaccinations, including COVID. Again, you know, we have like a 3-day seminar on vasculitis in Cleveland Clinic. So this is, I congratulate you all for holding it in a way that is done in 3 or 4 sessions. So please make sure that your patients are vaccinated, but do not delay treatment because they are not. So treatment is highly successful. Death sentence to 10 years, 5-year survival of 95% in some of them. And yes, there is a treatment risk, and morbidity is mostly due to irreversible damage and treatment toxicity. So, and the risk factors in different studies are increasing age and kidney damage. So put it all together, diagnose it clinically. So we had to go clinically, you know, it takes funding for their tests and everything, and CT chest is sometimes difficult. It is very hard. Yes, for paying patients it is there, but for a population of 120 million people in this country, teeming with health budget, less than even 3%. I don't know how we are going to manage these billions of sick patients of autoimmune diseases and make sure that you're screening for medical toxicity also. And please learn vasculitis. It's such a challenging thing. If you don't know it, you will not recognize it. And still remember a young boy, his whole childhood is gone forever. And hope this does not happen. Success comes with passion, starting from a very small clinic in a tertiary, in a small area to rheumatology departments in every hospital, of which Arthritis Care Foundation has trained almost a fourth of them through their own resources and funds for biologics and funds for this. With patrons like Professor Sarah Walker, we have this team which is working constantly with Arthritis Foundation. And I think if we have passion, we can transform lives, and together we can do it. And from this to Global Rheumatology Educational Initiative, from 8 rheumatologists in 1990 to coming to this has been a long journey, and empowering family physicians fighting disability. All this teaching and training is because of good friends like shown here. I can see Atik sitting there, and it is great. It was great at the PSR in Lahore the last time we had it, and my acknowledgements to my great team. And I am extremely thankful for giving me this opportunity. Thank you so much.
Thank you, madam, for your excellent speech about ANCA-associated vasculitis and its updated management. And we have seen you have used many very recent classification criteria of 2022. But unfortunately, we are missing your presence, madam. Professor Danda, Professor Devas Danda, Professor Salimi, all and reach us. Hopefully, in the near future, we'll be getting all of those, and they'll come to the. I request first Professor Sohail Mahmood Arafat sir, Chairman Internal Medicine, Bangabandhu Sheikh Mujib Medical University, give on
very good. Thanks to the organizers of today's session for allowing me to be here as a chair. I have listened to the wonderful lecture given by Professor Nigat Ahmed. That covered everything. I'm here just to learn from this brilliant lecture. And thank you very much. Thank you to listeners. Thank you so much.
Come there again.
May I now request Sir Kazi Tariqul Islam sir, the legendary professor of medicine, to give some comments on today's lecture.
Thank you, ma'am. Your lecture was wonderful on small vessel vasculitis, and I must express my gratitude to Bangladesh Rheumatology Society that they have the confidence on me to chair the session. Actually, I can remember one incident in my life. With that, I will end. When I am assistant professor in 1991, I came across with an old man who presented in the ward with breathlessness and oliguria. And that time, I was very young, and at that time, my age was not that much. In Bangladesh, rheumatology has come in the last 1.5 decade very much in a high leadership. Obviously, Professor Emena took baton. And when I was working in 1991, that I saw that the nose become shrivel and down. This old man and book. Ultimately, our test facility was very less. We took the biopsy and took help from ENT surgeon. I brought the sample from the northern part of my country to Dhaka. And Professor Nazrul Islam was alive at that time. He was kind enough to do the histopathology, and it came as, at that time, it was known as Wegener's granulomatosis. And the case was published. Why I am telling, present rheumatologist and young rheumatologist, they are so nice. In their life, they are getting so legend, like Syed Atiqul Haq, Nazrul Islam, Minhaz, and they are a leader in my country now. I think rheumatology is moving very faster, and today's lecture from Professor Nigar definitely will help us a lot, and our students as well as the teachers, they have been benefited a lot. Thank you very much once again.
Thank you so much, sir. Thank you so much. I really appreciate that.
Thank you very much, respected speaker, honorable chairpersons, and also thanks to moderator. Now I'd like to request our President Bangladesh Rheumatology Society, Professor Syed Atiqul Haq sir, please come up on the dais and hand over the memento to our chairpersons and to the moderator.
It was so good to see Nazrul. And,
First to Professor, first to Professor Sohail Mahmood Arafat sir, and next Professor Qadi Tariqul Islam sir. And another memento for Dr. Jahangirul Alam. Thank you. Now we're going to start our third session. This session will be chaired by Professor Dr. Mujibur Rahman and Professor Dr. Syed Monwar Ali. This session will be moderated by Dr. Sonia Nasrin Ahmed. The speaker of this session is Dr. Monica D. Silva. Now I'd like to request our honorable person and moderator to come up the dais. Sonia, তুমি শুরু করে দাও।
Assalamu alaikum and a very good afternoon to all of you. Welcome to the session 3 of today's program. Today we are joined virtually for this session by Dr. Monica De Silva. And before we start, a brief introduction. Dr. Monica De Silva is a consultant rheumatologist at the National Hospital of Sri Lanka, which is the premier tertiary hospital in the country. After graduating from the University of Peradeniya, she had her MD from University of Colombo, and she completed her rheumatology fellowship from the University of Alberta in Edmonton. Dr. Monica is the immediate past president of the College of Specialists in Rheumatology and Rehabilitation in Sri Lanka. She is also a member of the Specialty Board in Rheumatology and Rehabilitation of the Postgraduate Institute of Medicine in the University of Colombo. Of her many great achievements, one of her greatest achievements is that she has been able to begin the vasculitis registry recently in Sri Lanka, which is one of the first of its kind in the country. And she has several publications in the field of rheumatology. So without further ado, I will now hand it over to Dr. Monica De Silva, who is joining us virtually.
Thank you, Dr. Sonia, for kind words of introduction. Good afternoon to all of you. And first of all, I'd like to thank Bangladesh Rheumatology Society and Professor Minhaj Rahim Chowdhury for inviting me to do this presentation. In the next 20 to 25 minutes, I will be discussing non-immune complex mediated vasculitis. I'll discuss on associated disease entities and will briefly discuss on this, management of these entities as well. So this is a heterogeneous group, and this is characterized by the position of immunoglobulins and complements on the vessel wall. And this is predominantly small vessel vasculitis involving arterioles, capillaries, and post-capillary. According to 12 consensus nomenclature, there are 4 types of vasculitis classified under immune complex small vessel vasculitis. These are fibroblastic vasculitis, IgA vasculitis, hypocomplementemic urticaria vasculitis, and antiglobular membrane disease. In addition, there are other types of vasculitis which are mediated through immune complexes. So these are due to exogenous antigens, drug-induced. So drug-induced one also may be ANCA mediated, but it can be immune complex mediated too. So due to antibiotics, allopurinol, phenytoin, these are the few drugs that can cause immune complex mediated vasculitis. Usually begins after 7 to 10 days after introduction of the drug. And they also vasculitis can be due to infections, particularly chronic infections, chronic viremia with hepatitis B, or subacute bacterial endocarditis due to chronic bacteremia, and also with sepsis, which can occur mediated through immune complexes. And vasculitis associated with systemic diseases, lupus vasculitis, rheumatoid vasculitis, Sjogren syndrome vasculitis, and also vasculitis associated with malignancies, solid organ malignancies, and hematological malignancies. All these are immune complex mediated. However, because these topics are discussed in different lectures separately, I'll be concerned on these immune complex small vessel vasculitis, which are classified under Chapel Hill nomenclature. So this usually have skin involvement in form of palpable purpura, but there also may be ulcers, punched out ulcers, nodules, hemorrhagic vesicles, and bullae, and chronic urticaria as well. So pathologically, as I mentioned earlier, there's small vessel involvement, and presence of leukocytoclasis is characteristic. That's debris in the vessel wall. In addition to skin, other organs, lungs, kidneys, we will discuss IgA vasculitis, which was known as Eskaton purpura earlier, but revised Chapel Hill consensus conference nomenclature. It is replaced by term IgA vasculitis. So this is the commonest vasculitis in children, and it's rare in adults. Incidence in children is around 3 to 27 per 10,000, and in adults it's less than 2 per 10,000 incidents. And here pathogenic mechanism is involved this abnormal IgA subtype, that's galactose deficient IgA1. So this is the antigen, and the autoantibodies bind to this, and also soluble Fc receptors also can bind, and this is the pathogenetic mechanism that causes vasculitis following even complex formation. And it may present as single organ disease, maybe cutaneous only or renal limited, but it also can present with multi-organ involvement as a systemic disease. Classical triad is palpable purpura, arthritis, arthralgia, and gastrointestinal involvement. This palpable purpura is seen in lower limbs, but can occur all over the body. And usually children, this lasts 2 to 3 weeks. And in adults, so there can be severe necrotic lesions and hemorrhagic lesions as well, manifestation. Arthralgia and arthritis is not overt arthritis in IgA vasculitis, but they can have ankle and knee pain, causing difficulty in walking. Gastrointestinal involvement typically presents as colicky abdominal pain, usually occurring after 2 to 7 days after the appearance of the rash. However, it can present before as the first manifestation. It can present as colicky abdominal pain. And GI involvement also can cause bleeding. It can be bleeding or gross bleeding due to involvement of the duodenum and small intestine. Renal involvement in adults is more frequent and also with worse prognosis. In 30% progress into CKD or stage renal disease, and children about 10% progresses to CKD or end stage renal disease. And microscopic hematuria is subnephrotic proteinuria is the commonest presentation, but there can be arterial hypertension and elevated serum creatinine even at the beginning of presentation. There are no characteristic or diagnostic lab tests IgA vasculitis. In 50% of patients, IgA may be elevated, and C4 also might be reduced in minority. Characteristic IgA deposition in the renal biopsy showing IgA deposits with immunofluorescence, and even in skin biopsy specimens, IgA deposits are seen in the vascular wall with the immunofluorescence microscopy. These are diagnostic of IgA vasculitis. So how do we manage IgA vasculitis? Steroids are not effective for skin lesions, but effective for gastrointestinal and joint manifestation. For skin manifestations, colchicine, Dapsone, and montelukast may be effective, but these will not reduce the probability of recurrences. Renal involvement in IgA vasculitis, there is isolated microscopic hematuria. Follow-up is recommended, and if there's hematuria with subnephrotic proteinuria, but with normal serum creatinine, steroid monotherapy is adequate. And if there's severe renal impairment, There is no indication for immunosuppression because it can cause worsening of renal function. Only supportive therapy is needed. But if there is rapidly progressive glomerulonephritis, steroids and cyclophosphamide are indicated. Antiglomerular basement membrane disease, earlier known as Woodpasture disease, and it is also rare, occurring less than 2 per million people in Europe, and it seems to be rarer in black race, and there's a bimodal distribution in 3rd and 6th to 7th decades of life. When we present, there's no possibility of having lung involvement both, and usually there is slight male preponderance. And here, antigen is alpha 3 chain of this type 4 collagen, and the non-collagenous domain of type 4 collagen, and this is the autoantigen, and there is antibody formation, and which is the pathogenic antibody causing rapidly progressive glomerulonephritis, and in most of the patients, almost about 80 to 90% of patients, which is characteristic of biopsy, and in 40 to 60% can have concurrent lung hemorrhage, and they present with dyspnea, short dyspnea, and hemoptysis and rapid fall in hemoglobin. And imaging is helpful in the diagnosis and bronchoalveolar lavage too. Diagnosis is with demonstration of antiglomerular antibodies and by ELISA or immunofluorescence. And 10% can have negative antibodies even in the renal blood shows bigger changes with immunofluorescence showing ribbon-like staining of the glomerular membrane with IgG. And treatment with plasma to remove this pathogenic antibody. And immunosuppressants to reduce the antibody. And steroid classes and cyclophosphamide is indicated only in short term. The main way of treatment is removal of pathogenic antibody with plasma exchange. So, hypercomplementemic urticarial vasculitis is very rare and is predominantly female disease and typically present with during 4th to 5th decade. So, as the name implies, the patients with urticarial lesions which can be burning or painful, and these last longer than 24 hours and is healed with hyperpigmentation, and there can be post-inflammatory purpura. In addition to urticarial rash, the other clinical features include arthritis or arthralgia. They can have angioedema or laryngeal edema, uveitis, asthma, COPD, gastrointestinal involvement, and glomerulonephritis too. And the characteristic feature is low serum complement, and majority have anti-C1q antibody. These patients meet criteria for SLE as well. Cryoglobulin vasculitis, so this is characterized by presence of cryoglobulin, and these cryoglobulins are immunoglobulins which precipitate in low temperatures and dissolve with rewarming. So there are 3 types of cryoglobulinemia. Type 1 is characterized by presence of monoclonal IgM or IgG, and this is due to B-cell lymphoproliferative diseases, multiple myeloma, Waldenström-macroglobulinemia, and monoclonal MGUS, monoclonal antibodies with undetermined significance. So it's type 1 and type 2 and type 3 usually are associated with hepatitis C, chronic hepatitis C infection, autoimmune diseases, as well as B-cell proliferative diseases. So type 2 is the presence of monoclonal IgM. So we can see the same color both. So these are monoclonal IgM antibodies with rheumatoid factor activity. So these can bind to FC portion of IgG. These IgG are polyclonal. And in type 3, so these are polyclonal IgM. So you can see the two different colors of IgM. Polyclonal IgM with rheumatoid factor activity. So when there is no apparent cause for this, so these are identified as mixed cryoglobulinemia. Sorry, we name as essential cryoglobulinemia, and these two types are called mixed cryoglobulinemia, type 2 and type 3. So characteristic clinical presentation is Menetzel trial, which consists of purpura, weakness, and arthralgia. But they also can have renal involvement, commonly with microscopic hematuria and mild proteinuria, but nephrotic or nephrotic syndrome also can occur, which are rare. And non-proliferative glomerulonephritis is the characteristic feature in mixed cryoglobulinemia. And in addition, hepatic CNS, OGI, and cardiovascular involvements also reported. So treatment of cryoglobular vasculitis is needed whenever there is rapidly progressive glomerulonephritis with nephrotic syndrome. Need treatment with rituximab with or without steroids. So most of the times we treat these vasculitis with steroids. And if it is organ-threatening severe disease, immunosuppression has to be started before specific therapy. This can be done even in hepatitis C virus-induced cryoglobulinemia, but not with hepatitis B or HIV-associated cryoglobulinemia. These patients need antibiotic treatment before starting immunosuppression. And data supporting use of cyclophosphamide are limited in glomerulonemia vasculitis. So I just discuss two patients with one patient diagnosed as cryoglomerular vasculitis, 49-year-old man who had history of autoimmune hepatitis 10 years ago, and for 5 years he was getting joint pain, and he was treated with methotrexate, and he got admitted to a medical ward with methotrexate-induced neutropenic sepsis, and they referred the patient to us, and the patient was sent very high rheumatoid factor, more than 1,000. And he was sent for uric crash, and he had uric crash even before the year with the milder version, and then he found to have persistent microscopic hematuria, and because of high rheumatoid factor positivity, serum cryoglobulin was done, and these were positive twice. His ANA and NCover negative, and complement C4 was low, supporting the diagnosis of cryoglobulinemia, and his plasma protein electrophoresis was normal, and he was started on IV cyclophosphamide because he was having ischemic symptoms and microscopic hematuria. Patient didn't want to undergo renal biopsy, and even the nephrologist didn't want to do because it was only microscopic hematuria with mild proteinuria. And we started him on rituximab 500 milligram weekly 3 pulses, although the recommended dose in vasculitis is 375 milligram per square meter weekly 4 pulses. He started 3 pulses of 500 milligram, and he had complete resolution of symptoms, including the microscopic hematuria. And still he is in remission, and he is on MMF, and he is getting 1 or 2 purpuric patches once in a while on MMF. The other patient is a 60-year-old woman, and she also had history of purpuric patches for 3 years, and but not much medical attention was there, and so she also got admitted to medical ward with history of fever of 2 months, and she had arthralgia of mainly the large joint, and she had widespread rash over the lower limbs, particularly below knees, and she had systemic symptoms. Other than fever, she had loss of weight of about 10 kilograms, and in addition, while in the ward, she developed numbness of fingers in right hand, and she also had foot drop, unilateral foot drop, and she had the urine, and she also had generalized chronic seizure while in the ward. So her investigations were very high ESR and PRP, hemoglobin was low, and again rheumatoid factor was positive with negative ANA and ANCA. Hers also C4 was low. So we were thinking of diagnosis of cryoglobulinemia vasculitis because it's rheumatoid factor positivity and low C4 and high CRP. She had nephrotic proteinuria with the presence of red cells in urine, but with normal creatinine. However, repeated cryoglobulin test was negative. The viral screen for B hepatitis B and C were negative. Skin biopsy showed leukocytoclastic vasculitis, and renal biopsy there was acute diffuse proliferative glomerulonephritis, and nerve conduction there was mononeuritis multiplex, and her serum protein electrophoresis also showed normal band with 0.9 gram per liter, and but bone marrow biopsy was normal. So her clinical picture is suggestive of cryoglobulinemia vasculitis, but cryoglobulin were negative. So while in the ward, she was treated with prednisone 1 gram 3 days, followed by high dose oral steroids, and because of this severe vasculitis, cyclophosphamide was started. However, after 1 month or so, she was and the proposal was persistent. But so we started rituximab 500 milligram weekly 3 pulses previous patient, and her drop quickly responded to that and 40 milligrams and for 2 years she's on she's on MMA, and she had also she recovered fully without any complication. And after 2 years, she had another rituximab 500 milligram pulse because she had was in a flare of the rash without much involvement of other organ. So recently, she got another injection of rituximab. So, so thank you very much for giving me this opportunity, and wish you all the best for 14th scientific conference of Bangladesh Rheumatology Society. Thank you.
So thank you, Dr. Monica De Silva, for a very informative lecture on immune complex mediated vasculitis. I would now like to request the chair people to come and say a few words, starting with Professor Dr. Syed Mohammad Manor Ali. Sir, please say a few words.
Thank you, Dr. Sonia. Assalamu alaikum. It's my honor and privilege to be the chairperson of this session. I do express my gratitude to the Rheumatology Society. I feel myself very fortunate that I'm sharing the dais with someone like Professor Mujibur Rahman sir, the legend in internal medicine and rheumatology of Karnataka. Speaker of this session was Dr. Monica De Silva. She talked details about immune complex mediated vasculitis. Let me congratulate her for her nice deliberation. So a few words about vasculitis. It is, as we know, heterogeneous group of disorder with very clinical manifestations, and there is inflammation of the blood vessels. Clinical manifestations are varied, like they may present with simple cutaneous involvement to widespread organ involvement and tissue damage and some constitutional features. So any patient presenting with seen manifestations like purpura, gangrene, infarcts, along with unexplained fever, a constitutional feature, and organ involvement like pulmonary renal features, we should suspect vasculitis. Now, a few words about the classification of small vessel vasculitis. There are actually two broad subcategories of small vessel vasculitis. One is ANCA-associated vasculitis, and that is we call post-immune vasculitis, which is probably the most severe form of vasculitis we encounter. But fortunately, these are less often encountered in clinical practice than immune complex mediated vasculitis. They are very common. They are very common, and manifestations are diverse. As we saw, Dr. Monica told about drug-associated hypersensitivity vasculitis. She talked about cryoglobulinemic vasculitis. She talked about cryoglobulinemic vasculitis. So immune complex mediated vasculitis may appear as she told associated known as anoxion purpura. It may syndrome like that. Probably the most common form of immune complex mediated vasculitis is hypersensitivity against some drugs or infectious agents. So, allopurinol or phenytoin involved in hypersensitivity vasculitis. When hypersensitivity vasculitis involves only skin, we call it cutaneous plastic vasculitis. There are other distinct forms of vasculitis like complementary urticarial vasculitis or vasculitis associated with probable etiology. Like it may be associated with hepatitis C virus in the form of cryoglobulinemic vasculitis. Cryoglobulins are immunoglobulins. So cryoglobulinemic vasculitis is one very important and less often diagnosed in clinical practice. I'm discussing with a few minutes here. Probably we have no facilities in Bangladesh to measure levels. So we have limitations. And treatment, regarding treatment of immune complex mediated vasculitis, it may not require any treatment when it involves medicine or aggressive I will conclude my discussion. Before thanks to all delegates from home and abroad. Special thanks to government rheumatologist. You government rheumatologist, this is you. I am here, and to doctors of my Dhaka Medical College. My are here. You came in good numbers. Last, my heartfelt congratulations to Professor Mina sir, Nazrul sir, Shaheen sir, and my teacher, guru, and mentor, Sayyid Atiqul sir. Assalamu alaikum, and thank you.
Thank you, sir. It gives me great pleasure now to request one of our legendary professors of medicine, Professor Dr. Mohammad Mujibur Rahman, sir, to say a few words on today's.
Thank you very much. Nothing to say about the vasculitis, but Rheumatology Society has arranged this session vasculitis and SLE that has been creating a tremendous momentum, especially the junior doctors. I think if something about vasculitis among the junior doctors, then it will be very much helpful for those patients, those who are very neglected and mistreated among the countries. So thank you, Rheumatology Society, for organizing this sort of Dr. Monica De Silva has a nice speech, and she has depicted a picture of immune complex mediated vasculitis in a very nice way. And you know, this is the commonest form of vasculitis. And she has described all aspects of this form of immune mediated vasculitis. And I am congratulating her, Dr. Moni Silva, among the rheumatologists and junior doctors of Bangladesh. And we are very much delighted to have you amongst ourselves, though it is virtually. But we are hoping that in the future we'll be with you in face-to-face in anywhere among our countries, especially these countries. Thank you very much. Thank you.
Thank you. Thank you for a brilliant speech of our foreign delegate. Now, this is the time for moment to hand over. Now, I'd like to request Professor Dr. Abdul Razzaq, Brigadier General, Chief Physician, Armed Force CMH, sir, come on the dais and hand over the moment to our respected chairperson and moderator. Sir, army look the doc, sir.
Thank you, organizer. স্পিকারদের আমরা এই চেয়ারপারসনদের আসলে স্পিকার মানে আমাদের এই মোমেন্ট দেওয়াটার আসলে দরকার নাই। উই আর হিয়ার and that is our honor. Thank you very much.
Next part, I'd like to request our chairpersons to hand over moment to our moderator. Yes. No problem. You three guys can hand over. Thank you, sir. Thank you. We're going to start our fourth session. The speaker of this session is Professor Minhaj Rohim Chaudhuri and Professor Arup Kumar Kundu. This session will be chaired by Professor Sobhan Bishwas and Professor Raushonara. Sobhan Bishwas. Okay, sir. And the program will be moderated by Dr. Mohammad Ariful Islam, Assistant Professor Rheumatology, Bangabandhu Sheikh Mujib Medical University. I'd like to request chairpersons and moderators to come.
আস্তে ধীরে জিনিসটা বোঝা যাবে
Assalamu alaikum. Welcome in our session 4. We have speakers section. Rem Chaudhary, our chairman, Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University. Before going, I'd like to Professor Minazram Chaudhary, currently working as professor and chairman, Department of Rheumatology, BSMMU, Bangladesh. He joined Indian University in 2003. Before that, he served as an assistant professor and assistant professor in Shoaib Sarwardi Hospital, Sir Salim Medical College, Dhaka, from 1999 to 2003. He worked as clinical and research fellow in the Royal Hospital in School, Hampstead, 2002. He became Fellow of American College of Rheumatology in 2006. Professor Chaudhary served as resident physician from 1996 to 1998. He did MBBS from Sir Salim Medical College in 1984. He obtained in 1995 and in 1996. Professor Chaudhary now serving as Secretary General of Bangladesh Rheumatology Society, has authored and co-authored of numerous scientific articles in national and international journals and presented several scientific papers in home and abroad. He attended several basic and advanced muscular ultrasound courses in USA, Hong Kong, Malaysia, Philippines, and organized and acted by ACR, Euler, and Appler. Professor Chaudhary was speaker at the muscular ultrasound course in 21st Congress on 7th April 2019 in Brisbane, Australia. Now I request Professor Minazram Chaudhary sir to deliver his speech. He will speak on application of ultrasound in the diagnosis of large vessel vasculitis.
Mr. Chairperson, teachers, learned audience, Assalamu alaikum. Today I will talk on a role of ultrasound in large vessel vasculitis. So it's a different kind of topic, and so this is our lovely campus, our university, and the importance of musculoskeletal ultrasound is increasing day by day. And many rheumatologists believe that musculoskeletal ultrasound should be the stethoscope of a rheumatologist. Learned audience, we will try to demonstrate you the machine practically today, just outside of this room. And if you have some interest, then you must go to our pavilion. We are trying to show you practically some pics, and so you will, if you do not have any exposure, you will have the exposure. And I understand many of you are clinician here, and naturally you may not have enough exposure, limited exposure, or even some do not have any exposure too. And therefore I would like to spend a couple of minutes in my introductory slides, and also the introduction of the machine and the procedure. So musculoskeletal ultrasound is mostly used by the rheumatologist, and it has used, and I think you have seen our previous speakers, they have showed it also may be used in the diagnosis of vasculitis and also the monitoring of vasculitis. So what is it really? So it's an imaging modality. And how does it work? It utilizes reflected pulses of high frequency sound waves. This is very important. So it produces images and it uses high frequency sound waves. And these high frequency sound waves really produces images. And in musculoskeletal ultrasound, we use grayscale. Grayscale means the images it produces, these are in a black and white format. Now for vasculitis, what happens? We use another mode. This is colored Doppler. We need to use colored Doppler, and colored Doppler what is it? Then it is just, it superimposes color on a grayscale background. That is important. And when we consider that we need to look at the blood vessels, and if we suspect that patient may have stenosis or occlusion, then definitely this color Doppler. There are several buttons on the machine, and you have to press that button and it will work accordingly. So in rheumatology practice, we can detect pathologies of different organs, like different like joints, bones and cartilages, tendons, synoviums, ligaments, muscles, vessels and nerves. So today our interest, or we will focus on vessels. That is important. Today we will talk on vessels pathology for the diagnosis of vasculitis. So these are some activities in our department, and we are active both in home and abroad. So here you can see there are some pictures. It was in Brisbane, Australia, and here he was a trainer. Already Dr. Arif told, it was in Kathmandu, Nepal. And so like last 7 to 8 years, we are practicing in our rheumatology department, and we have a lot of interested doctors with us. And you can see this is in Dhaka, our interested doctors, they are here. And also there are many experts, they are coming in Dhaka from Europe, Australia, Asia, and there are wonderful exchange of views. And here you can see one gentleman, he is from Germany, Wolfgang Smith, and he was also with us in Dhaka, and he has lots of work on vasculitis and uses of ultrasound on vasculitis. And we are also trying to utilize our media to really aware our people about rheumatology and rheumatology related diseases. Now let's move to my main presentation. First of all, so I will talk on large vessel vasculitis. So basically there are three types of vessels, and small sized, medium sized and large sized vessels. So what are those really? So the large size vessels, if we want to define, we can define in this way: consist of more than 150 micrometer with muscular walls. They should have muscular walls. So examples are aorta and its major branches. And by this time you have come to know that the large vessel vasculitis include mainly giant cell arteritis and Takayasu arteritis. And the most important part is how the really ultrasound will help us. So ultrasound will be able to visualize wall thickening, which is very much characteristic for the diagnosis of arteritis and arteritis. And it has been reported that in cases, even may replace his pathology, biopsy. So today, none of these speakers really touched giant cell arteritis. And let me take the privilege, and I'll show you just only 2 slides on clinical features and also the lab investigations on giant cell arteritis. And it mostly affects individuals aged more than 50 years, and it is usually characterized by localized headache, and could be accompanied by swollen and tender temporal arteries, and there may be jaw claudications, and most devastating manifestation could be ophthalmological complications, what we say anterior ischemic optic neuropathy, and patients may develop vision loss very quickly. ESR and CRP is usually raised, and still the temporal artery biopsy is considered as the gold standard. However, it has got moderate sensitivity, only 39 to 67%. So you understand there is an unmet need uh, for the development of something else. And if we do histology in giant cell arteritis, what we expect, there will be features of vasculitis and with a predominance of mononuclear cell, granulomatous inflammation with or without giant cells. So how ultrasound can help us for the diagnosis of large vessel vasculitis? It can detect increased intima media thickness, and it reflects really inflammation in vessel wall. This is very important. So we need to remember intima media thickness, and OMERAC, a very well-known group, they have defined what does it mean, intima media thickness. So it's an area of tissue should be started at luminal edge of artery and ending at boundary between media and adventitia. So we need to measure this area by ultrasound, and that can be measured. And why it happens? It occurs due to migration of myofibroblasts into intima media complex. And so if we allow this increased thickness, it will subsequently causes stenosis, occlusion, ischemia, and damage to end organ tissue. So early detection and early management is essential. All of you know, in the concept, now it is said, we call it paradigm shift. So now in rheumatology practice, in most of the diseases, we have to intervene as early as possible. So when we find intima media thickness is increased, we call it halo sign. Today in the early morning, when Dr. Tabir and Professor Shaheen was conducted our session, I think looking to know this about this sign, halo sign. So here, this halo sign is really this increased intima media thickness. And this OMERACT group also defined is a homogeneous hypoechoic wall thickening that could be visible by the ultrasound, and but it should be seen in both longitudinal and transverse plane. And this halo sign, so halo sign also should be verified by compressed sign. So what is, so we have to compress the lumen by the probe. So if the halo sign, true halo sign is there, it will not disappear. But if it is not the true halo sign, it will disappear. And this is called compression sign positive, and it has got very high sensitivity and specificity. So we have to detect what I have said. We have to detect halo sign, that is intima media complex. These measurement, normal measurement, so it will be increased. That will be called halo sign, and this halo sign will be verified by the compression sign. If it is true halo sign, the compression sign will be positive. So we can look here. So this is a normal blood vessel. Here we can see this is temporal artery. This is called longitudinal view. You have to remember the ultrasound has got its own language. And here we can see this is a normal blood vessel in transverse view, and this is longitudinal view. Longitudinal view means when we place our probe in longitudinal axis, longitudinally along the blood vessel. And this one is the transverse view, when we place transversely. So this is normal, and there is pathology. There is vasculitis. How can we say there is vasculitis? If you look at the arrow, so there is, this is we call hypoechoic or gray areas just outside the lumen. So I have already told you that the ultrasound has got its own language. So ultrasound tell it is hypoechoic. Hypoechoic means gray. So if we can detect this area just outside the lumen and inside adventitia, we can say this is probably the intima media thickness has been increased. So we need to measure it. We can measure it. And this is the transverse view where we can see around the blood vessel this gray area. So we can say, well, it is halo side. Now we need to compress it by our probe. If it disappears, then this is not true halo. This is probably pseudo halo. And if it persists, this is true halo. This is the now this is pseudo halo. So there is a pitfall, we understand, and we need to confirm it. Why it happens? So when we detect that the area is not hypoechoic, the area is not gray, rather the area is anechoic or black. So you will guess that it could be pseudo halo. And then we have to look at the machine equipment. So there may be some error with the machine, and then we need to adjust. And sometimes even the hair, such as the scalp, especially in parietal area, it may produce some kind of pseudo halo. We have to keep it in mind. All of you know this, just a recapitulation of the anatomy. So here we can see this is the common carotid artery and the external carotid artery. And this is superficial temporal artery. This superficial temporal artery is very important for the diagnosis of giant cell arteritis. And so what we do, we really place our probe in front of the ear, and then we will proceed toward the scalp. So we can see it in picture. So on the left side, first we are trying here to see the temporal artery. That is very important. And it should be placed longitudinally, this probe. So this way, and then in the next picture, here you see this is temporal artery picture. And you understand this is normal because just show you the normal one. So this is normal artery lumen, blood, etc. So this is Doppler. And in the next picture, now we are proceeding toward the frontal branch of the temporal artery. So this is the longitudinal view of the frontal artery. And then we will target parietal branch of the temporal artery. And this way we will come back, but when we will come back, we will use the transverse one. Transversely, we will place the probe. So this is the way we have to perform it. I've already told. So now, what about the Takayasu arteritis? So we need to examine that like subclavian, also vertebral arteries. These are the arteries when we suspect that a patient may have Takayasu. These arteries, subclavian, carotid, vertebral, etc. So this is again anatomy. If we look at, so this is the, you see this is aorta, this is subclavian, we can see here. So this is the left vertebral artery, and ultrasound can detect this left vertebral artery very easily. And then this is left subclavian artery. Also, we can see left axillary artery. And similar things will happen on the right side also. Now, this is the place. Here we have to place our probe in front of the sternocleidomastoid, and this is above the clavicle. So this is the place to detect carotid artery. And then we need to, as I already said, vertebral artery has to be localized, and visualization of this vertebral artery requires identification of carotid artery first. And then if we place our probe transducer slightly pointed laterally, then we will be able to visualize vertebral artery. Why we need to vertebral artery? Why we need to visualize vertebral artery? This is another important point. If we can visualize vertebral artery, then we will try to compare carotid artery blood circulation with the vertebral artery. If there is any discrepancy between two, then we will understand that there may be subclavian steal syndrome. So you see, you can also detect subclavian steal syndrome by the help of ultrasound. And this is the place for right subclavian artery that can be seen. And here, space for left subclavian artery, you can understand just this is above clavicle. And in the upper panel, you can see this is really grayscale, black and white image. And then you can proceed toward the axillary artery, proximal axillary artery, and then eventually we have to look at the distal axillary artery. So distal axillary artery also can be visualized. You can see here, this is distal axillary artery. And Dr. Farzana Shumi, in her lecture, she has shown the importance of looking at the axillary artery. Although it is very much important for the diagnosis of giant cell arteritis, but now there are also literatures are coming up that it has got importance the diagnosis of Takayasu arteritis too. So that is important. And there may be again some pitfalls. So here we can see excessive color, and so machine adjustment will be required. Here we can see already I have said this is pseudo halo. So anechoic or black areas outside, so we have to ignore. And another important point is atherosclerosis. So sometimes we may be confused. If there is atherosclerosis in the vessel wall, we may presume that it could be halo sign. So we need to differentiate atherosclerosis versus halo sign. Intima media thickness is there, and sometimes it may become very difficult to differentiate. So there are several studies, and the studies report showed here we can see it has got definitely higher sensitivity and higher specificity. The ultrasound has, and the studies also compared ultrasound to temporal artery biopsy, and some studies they've showed superiority of ultrasound to even temporal artery biopsy. And there are two studies they compared ultrasound to MRI, and it was found to be comparable. So both ultrasound and MRI could be comparable. So you easily understand it's much more easier to do ultrasound in comparison to MRI. And we can see some dynamic pictures. That is another plus point. And there are some cutoff values defined and for intima media thickness. So here we can see one, like if we see the temporal artery, superficial temporal artery, and we find the cutoff value is 0.42 millimeter or above. So its sensitivity is 100% and its specificity also 100%. So it's really very interesting. We have to note. And similarly, other arteries also, there are cutoff values are set. So, and you can see the sensitivity and the specificities are also reported. And there is one landmark study, it's called Tabul study. And Tabul study really compared the temporal artery biopsy versus ultrasound. And they showed sensitivity of ultrasound was greater than the biopsy. But the biopsy definitely had higher specificity than ultrasound. That is important. And then it is also said that if specificity of ultrasound may be increased to 95% or more if halo score is 10 or more. So recently in 2020, one scoring system has been developed that is called halo score. So this halo score, if it is 10 or more, it will increase the sensitivity of the, specificity of the ultrasound for the detection of vasculitis. So this is halo score, and I am not going through the details. It's a little bit complicated. But we have to just understand that if the score there are just 48 out of 48, if the score goes above 10 or more, it will confirm your diagnosis that this is giant cell arteritis and with high specificity. European League Against Rheumatism, EULAR, now they have changed their name. So they have recommends ultrasound of temporal arteries should be the primary imaging test in patients with suspected cranial giant cell arteritis. So that is very important that we have to learn ultrasound, and I'd like to request all our junior colleagues they should try to learn these technologies as early as possible. And in addition, ultrasound of the facial and occipital arteries also will increase the sensitivity. Also, I didn't show it in my slides. And these ultrasound also may help us in monitoring these giant cell activities, treatment. Several studies showed that halo was not visible in majority of patients after 2 to 4 weeks of introduction of glucocorticoids. So this is very important. If we put our patients on glucocorticoids, definitely, the mainstay of treatment still in giant cell arteritis is glucocorticoids, and we usually start 1 milligram per kg body weight. So this is very interesting that if we find the halo sign is positive, and within 2 to 4 weeks, this halo sign will disappear. Now let's move to Takayasu arteritis. And when we will suspect that our patient may have Takayasu arteritis, so we will ask for definite ultrasound, and we will look at subclavian and common carotid arteries. I have already showed, and Dr. Farzana, she also showed that abdominal arteries, these are the other areas we need to look at. And sometimes we may be confused whether it is only and also the also utilize also in Takayasu running the disease activity. And in the early morning again, in our quiz session, those who were present, they came to know that the difference between the macaroni sign and halo sign, this was also used. And when we try to say the Takayasu arteritis, and some rheumatologists prefer this term, macaroni. And so the thing is almost same. The intima media thickness is increased, and therefore nowadays believe that we can also tell this is halo sign. So we don't need to differentiate either whether it is macaroni or it is halo. So we can say also in Takayasu also we can say this is a halo sign. So this is the difference between macaroni sign, halo sign. So macaroni sign here we can see a little bit echogenic, and this is halo a bit hypoechoic. So if you practice, then still we are learning, and a bit difficult. It's not that easy really. If we say ultrasound, we may presume that it's something like very easy, but it's not really that easy. It's really difficult, and we need practice again and again. So these are the pathologies that can be detected in Takayasu arteritis. So here increased intima media thickness in common carotid artery, you can see. And here this is in vertebral artery, intima media thickness we can detect, and here in left subclavian artery. Now, this is one of our patients, a 45-year-old woman diagnosed with Takayasu arteritis in 2000. And she was treated with oral prednisolone and methotrexate, and her symptoms subsided. She was lost to follow-up due to COVID pandemic and discontinued all our medications. And recently, she again came to us with fatigue, claudication, pain in both her upper limbs. And on evaluation, we found she has had absent pulses and non-recordable blood pressure. And also our ESR rose to 45, CRP was positive. So we did her ultrasound, and you see our teammate here, Dr. Jahir, Dr. Arif, Dr. Azad, Dr. Atik, and so I have acknowledgement for them. They are really very helpful. And all our teammates in our department, really, they are showing very much interest in ultrasound. It's really inspiring for us. So here we can see this is the positive sign I wanted to mention, positive compression sign. We have to remember positive compression sign is important. It will increase the specificity and sensitivity. And another case, this was seen by Dr. Farzana, a known case of arthritis since 2012, and she was treated with azathioprine and corticosteroid. She was symptoms-free for 7 years, again developed malaise, occasional claudication pain, and then she did her ultrasound, and we can see here, you see the increased thickness, intima media thickness has been increased, and it was revealed by the colored Doppler also. So learned audience, in conclusion, I'd like to say ultrasound has become a valuable diagnostic tool for various rheumatic conditions as well as in large vessel vasculitis. It helps establish diagnosis early and thus may prevent several complications related to these conditions. And it doesn't need any extensive preparation. It's less expensive. It gives us really dynamic pictures, and the requirements are only a good equipment and 15 to 20 minutes of time. Thank you very much for patient hearing.
Thank you, sir, for this brilliant and time-demanding lecture. We all know that if we do ultrasound, even we can deny the temporary biopsy for diagnosis, giant cell arteritis. I'd like to thank Dr. Shoban Bishas from Kolkata. He joined as the chairperson for this session. Now I like to request Professor Dr. Anup Kundu. He will deliver a speech on connective tissue disease associated vasculitis. Arup Kumar Kundu, yes. I have introduced himself. Dr. Arup Kumar Kundu is ex-professor of medicine and head of development of rheumatology clinic of different medical colleges. He has served government sector for more than 25 years. And he's renowned for sharp clinical acumen, analytic approach, and clarity of expression. Dr. Kundu, a dedicated teacher, is known all over as motivator or booster of students. In the modern clinical field, Dr. Kundu is a prominent and competent name from India. He has authored very popular 6 books on clinical medicines, single-handedly, chapters in national and international books of repute with 121 index publications. The student-friendly clinical scientist is well known all over for his proficiency as eminent academician, renowned rheumatologist, astute clinician, brilliant author, and master teacher in internal medicine. He is a fellow of ICP India and member of New York Academy of Science, USA. He is the immediate past chairman of IRA, WB chapter, India. His biodata is included who's WHO in the world in 2014, 2015, 2016, and in Wikipedia. Now I like to request Professor Dr. Arup Kumar Kundu to deliver his speech. Thank you.
Sorry to interrupt. I like to give one announcement. We have live quiz program upon today's session with attractive prize including iPhone 13. Please scan your barcode on iPhone board on the gate of the ballroom. This is sponsored by Healthcare. Another announcement, another lottery arranged by SKF with 15 attractive prize including television, laptop, deep freeze, washing machine, Litman Stetho, so many, lot of prizes. Please don't miss to collect coupon from SKF Pharmaceuticals. And another important announcement, please don't rush for lunch before ending this program. All the rooms for lunch is locked. So please don't rush for, this is very important session. So please finish this session attentively and go for lunch. And delicious lunch is ready for you all. Thank you.
Next.
Sorry. एक कुंडू it is written. I have given it there. আমি দিয়ে দিয়েছি। সকালে হাতি কেন তুমি एक कुंडू
Announcement, we have poster presentation session. A total 10 poster already attached outside. We have jury board headed by Professor M. Mustafa Jaman. He will evaluate with his team properly just after lunch. Please attend your poster just after the lunch for proper evaluation. Thank you.
Good afternoon, everybody. It is my proud privilege to be here and to use this podium in front of this August gathering in Dhaka, being invited by few of my friends and well acquaintance of Bangladesh Rheumatological Society like Dr. Minhaj, Dr. Atik, my friend. I promise I will not stand in between the lunch and you. Though many of the students, juniors are really hypoglycemic. I'll give some telegraphic message, very boring topic from the morning, vasculitis, vasculitis, vasculitis. Just let me see. It is a connective tissue disease associated vasculitis. So today morning, we have learned a lot of vasculitis, the new classification of Chapel Hill classification 2012, the large vessel, small vessel, medium vessel, variable vessel, immune complex associated, tank associated, now came to our bedside methods. Like we see very often the rheumatoid arthritis, vasculitis, etc. These are known as connective tissue disease associated vasculitis. So this vasculitis is very rare and is reported roughly in 10% patients. SLE has got the highest association rate, and any size of the vessel may be involved, but the small vessel vasculitis are the constant. Any organ may be involved, and the treatment depends upon the type and the severity one. Previously, the secondary vasculitis was newly nomenclatured in 2012, that is revised Chapel Hill classification as vasculitis associated with systemic disease. That is a new variety. And it is written rheumatoid vasculitis, SLE vasculitis, and sarcoid vasculitis. We see not a lot of cases, but sarcoid vasculitis. Others means rheumatoid arthritis, polymyositis, Sjogren syndrome, etc. And the common skin manifestation of all these diseases are commonly nail fold infarct, petechiae, papura. We all are acquainted with this at our bedside. Digital ischemia and even gangrene. One physician should be warned and alarmed to see this, whether a systemic involvement is coming or not, like cryoglobulin necrotizing vasculitis. If suspected, then we must be cautious. This is the latest classification, and the red ink is my topic. Vasculitis associated with systemic disease. Rheumatoid lupus, sarcoid, and others. Others means our bedside. Every day in our clinic, we see rheumatoid, vasculitis, etc. So, we know what is connective tissue disease. Any disease that has the connective tissues of the body as a target. We know what is vasculitis from the morning. We have learned it many times. It is a heterogeneous group of disease where there is necrotizing inflammation of the blood vessels. CTD associated vasculitis are many, like RA, systemic sclerosis. I am telling this. SLE is the classical prototype of this, and lupus vasculitis and rheumatoid vasculitis are the best known connective tissue disease associated vasculitis. Other connective tissue disease, what the students want to know from me, the postdoctoral, like Ehlers-Danlos syndrome, Marfan syndrome, epidermolysis bullosa, and many a time they come with vasculitis, very rare variety. It is out of the topic. These are hereditary connective tissue disease. So vasculitis, this type of vasculitis may be primary or secondary. Primary means identifying a specific idiopathic vasculitis coexisting with that autoimmune disease like rheumatoid. Rheumatoid arthritis may not present as rheumatoid vasculitis, may be primary or secondary to the underlying disease. So one must remember vasculitis is usually primary may be occurred and secondary from the disease. Now entering into the subject, lupus vasculitis occurs in roughly 10 to 25 patients, and skin manifestation are the commonest one. Mostly females are affected, but many of the studies show males are affected more. Few of the studies. And generally, last line is important, SLE patient with vasculitis are generally younger than the patient without vasculitis. SLE vasculitis, SLE flares with vasculitis are associated with how we can diagnose, like anti-dsDNA antibody, low CD3. Cutaneous and vascular involvement. Cutaneous involvement, I've told petachi purpura, visceral, all the viscera may be involved. From the lungs, kidney, and the peripheral nerve is one of the commonest target organ. Even coronary appendix, all are encountered. Necessary spatial entity where patient comes with acute abdomen, vomiting, diarrhea, and fresh blood with stool, and often referred by us, the clinicians, as lupus enteritis or GI vasculitis. It is very serious and potentially fatal. Lupus vasculitis usually affects the small vessels. Large vessel vasculitis are uncommon. Now, all vasculitis in SLE, leukocytoclastic vasculitis predominant vasculitis. Second paragraph is very important. Around 20% lupus vasculitis precedes in an average of 3 years before the full-blown picture of lupus. This is clinician's era. So you have to diagnose it. Vasculitis fully develops after 3 years. Different studies shows that higher prevalence anti-dsDNA, anti-ribosomal protein. We recommend this for the patient. You do this and we see the reports. Anti-Rho and anti-La antibodies are very commonly present. This is a common picture. First picture, I give it in quiz. This is a beautiful artistic picture. It is lupus urticarial vasculitis. It is from a patient. Then second one is palpebral purpura. Third one is libido reticularis, the cyanotic mottling of the skin. CNS vasculitis in lupus is very, very rare. A patient of lupus with hemiplegia don't jump over CNS vasculitis because common causes of nervous system dysfunction in lupus are metabolic causes, dyselectrolytemia, infection, and thrombotic occlusion from APA syndrome or from the heart. Now, rheumatoid, the second one, these two are very big, others are very small ones like rheumatoid vasculitis is probably the most widely recognized vasculitis. Now, form of secondary vasculitis, as in other CTD, vasculopathy occurs. Vasculopathy, both are different terms. The prevalence of rheumatoid vasculitis occurs roughly in 2 to 3% patients, and usually males are more affected. When males are more affected than the females, an average duration of rheumatoid is roughly 11 years when the vasculitis appears. Again, that small vessels are mostly affected with skin manifestation. This is the Scott and Bacon criteria. This is how rheumatoid vasculitis is diagnosed at the bedside. Just you see. So, presence of one or more following in a patient of rheumatoid, mononeuritis multiplex, like peripheral neuropathy or neuropathy at a time involving many nerves, peripheral gangrene or biopsy evidence or cutaneous ulcer or pleurisy pericarditis, any two give you the clue. But other causes of the patient simultaneously present in the rheumatoid, like atherosclerosis and diabetes, should be excluded first. This is how the patient presence of rheumatoid vasculitis. We all know this. The learned persons present, everybody knows this. Just see, melee, weight loss to fever, ultimately pleural effusion, scleritis to ischemic colitis. All these are features of rheumatoid vasculitis. Diagnosis and laboratory tests. Anemia, acute fast reactant elevation, high platelet count more than 6.5 lakh, leukocytosis, and high titer of anti-CCP and rheumatoid factor, because there is no specific laboratory test to diagnose antibody for rheumatoid vasculitis. So diagnosis, maybe if you are confused, can be done biopsy, histologically neutrophilic infiltration of the vessel wall. It is important to know the causes of vasculitis. In this patient, the rheumatoid, hepatitis C associated cryoglobulinemia. Don't jump to the diagnosis. Patient is having deformed rheumatoid vasculitis. Medicine is not always 2 + 2 is 4. It is usually 2 + 2 5. You have to exclude hepatitis B, associated polyarteritis, and ANCA-associated vasculitis. Treatment is similar in all the patients, high dose of corticosteroid, and ultimately with the preference you can give azathioprine, methotrexate, and cyclophosphamide. Rituximab, tocilizumab is very promising drug for rheumatoid vasculitis. These are the classical picture of rheumatoid vasculitis, very painful. Patient is in agony, commonly affects the male more than the females. This is my patient, vasculitis in systemic sclerosis. He presented to me at 2006. Vasculitis for the students in systemic sclerosis is very rare. It is vasculopathy. These questions usually I give in entrance exam or postgraduate everywhere. Vasculopathy, vasculitis is primarily rare, but we know it is gangrene, etc. It is vasculitis. No, the two processes differ in their pathogenesis. In vasculopathy, epithelial cells apoptosis, myelofibroblast proliferation occurs. Whereas in vasculitis, histopathologically, there are some inflammatory infiltrates. Again, that small vessel vasculitis commonly affected ulcers, gangrenes, if associated in a patient of scleroderma or PSS with pulmonary hypertension. It is a very poor diagnosis. It is a picture from book that just you see diffuse alveolar hemorrhage in a patient of scleroderma, and it is written computed tomography scan of chest showing pulmonary hemorrhage in a patient of scleroderma associated with myeloperoxidase positive ANCA. So you have to remember all these things. Simple things. Sjogren syndrome with vasculitis, it also affects small vessels. It is connective tissue disease oriented. The tongue of Sjogren, I have shown it here. The skin and peripheral nerves are commonly affected. The Sjogren syndrome patient many a time comes with palpable purpura in the foot. It is the picture is given in Kelly's rheumatology book, and this is the feature of vasculitis in Sjogren syndrome. Again, MCTD, it also may present with vasculitis, and the cutaneous and neurologic features are more common, and the same thing is written here. Vasculitis in polymyositis and dermatomyositis, just the heliotrope rash is there. Vasculitis in PM and DM, again, is very rare, very rare. Previously, it was known that paraneoplastic dermatomyositis is associated with vasculitis. But however, later studies did not confirm this. But you all know that juvenile diabetes, dermatomyositis is usually associated with vasculitis. Commonly, the patient have got dermal or subcutaneous nodules, periungual hemorrhage, etc. Common picture of relapsing polychondritis, very rare, but you may see one or two patients in your whole lifetime. Just you see the red ear, looks like otitis externa, and just you see the nasal breeze collapse. Immediately spot diagnosis relapsing polychondritis, and it has got vocal cord involvement, cartilage involvement, and in myopathies, it also occurs vasculitis. Last vasculitis is sarcoid vasculitis. It is within the criteria of Chapel Hill. The skin lesion, it is lupus pernio, and you see the hilar prominence in the X-ray. It also affects the small and medium vessel mainly. Vasculitis in sarcoidosis. Sarcoidosis, I teach my students, is not a pulmonary medicine disease. It is a disease for rheumatologists. New inclusion for last 10 to 15 years. It may be pulmonary or extrapulmonary involvement. Line is important. Necrotizing sarcoid granulomatosis is a rare systemic disease characterized by sarcoid-like granuloma, vasculitis, and variable necrosis, mimicking pulmonary vasculitis. Now, just 5 minutes, just look at it. I'm coming from bench to bedside, a great challenge for everybody. A real life story. Only single case. A 52 years patient came to the chamber with deviation of mouth towards left, allowing drooling of saliva for 1 day, unable to close her eyes. She also complained of mild headache for past 3 months, and for sorry. In photosensitivity. Just but happened. These are the pictures that bilateral PIP, proximal interphalangeal, and MCP joints are tender, wrist and knee joints are on examination showing swollen. You can see the swan neck deformity in the hands, little finger, and the buttonhole deformity. It is very prominent in right little finger. So, started examination. Temporal artery normal. Any skin lesion of leprosy, especially in West Bengal, the coastal zone, and the Gangetic zone. No features of leprotic lesion. Parotids normal from sarcoid. Ulnar nerves normal. One brilliant doctor did this because the patient complained of headache, and headache. If a patient of Bell's palsy or lower motor neuron facial nerve palsy comes to you with repeated headache, you should do this MRI. And it is found that basal ganglia hyperintensity with periventricular hyperintensity. This came to us. Now, headache persisted. So, lumbar puncture was done. CSF cell count 7 per high powerful, failed all lympho, protein 60, ground stain, Jaden stain, lens, fungal stain, viral incompatibility marker, all negative. No oligoclonal band. Antibody, that is myelin oligodendroglycoprotein. That means multiple sclerosis, omitted. Anti-aquaporin 4, that is Devic's disease or something, antibody are all negative. Immunological test, rheumatoid factor positive, anti-CCP highly positive, CRP positive, A negative, complements normal, MPO normal, PR3 normal, that is negative. So Or secondary for rheumatoid vasculitis, many a time brain biopsy is needed. Who does this? Nobody knows. It is a case of probably primary CNS vasculitis, not rheumatoid vasculitis. Last you see CNS vasculitis secondary from other causes, last line this connective tissue disease, what I have discussed, and many other times infection and others are causing vasculitis. So in the conclusion, I may be allowed to say that vasculitis in connective tissue disease is quite rare, but SLE has got the highest association rate. Both existing are primary vasculitis and secondary vasculitis to the CTD. The primary vasculitis associated with the connective tissue disease are mostly cryoglobulinic vasculitis and PAN. The prevalence varies on the particular disease, and the organ involvement, visceral involvement is many a time serious. Cutaneous lesions may be a warning sign that visceral involvement may come. Corticosteroids are frequently employed in case of severe involvement. Cyclophosphamide and other immunosuppressive agents may be needed. Thank you. Thank you for your patient hearing. Thank you. I am in time or before time. Sure, I committed you. Thank you all. Sorry.
Thank you, Professor Anup Kumar, for his nice, brilliant presentation and sharing his experience. Now, I like to request our chairperson, Dr. Shobhan Bishwas, to have some comment on these lectures.
I invite Dr. Minaj and Dr. Arup over here, and this session is now open to question. If you have any question, you can put. I think 2 questions can be allowed.
Okay, can anyone have any questions on specific speakers?
So I think there is no questions. If any questions that come later, that can be solved in the lunch hours. And, you have any question? Dr. Parashar, please.
I am Dr. Parashar from Calcutta. I have a question to Dr. Minhaj. Actually, giant cell arteritis and arteritis, if you look histologically or maybe radiological signs, they're all similar. If you do biopsy shows basically pan arteritis. Can you hear me? So, giant cell arteritis and Takasu arteritis, if you do biopsy, is pan arteritis, granulomatous pan arteritis.
Dr. Parashar, will you please repeat your question? Please come forward.
I am Dr. Parashar from Calcutta. So, the giant cell arteritis and Takasu arteritis, they are both similar. Histologically, they shows pan arteritis with granuloma. Basically, granulomatous pan arteritis. If you do radiology, it shows again halo sign or similar sign or macaroni sign, whatever you say. Now, then how do you, in a patient who is borderline age, say 50 years or 55 years, if you present, how do you differentiate?
Oh, okay. Okay. Thank you, Dr. Parashar. It's a very good question and relevant question. So, again, what we have learned, the history, clinical examination, we must not forget. So, again, the age is very important here. The Takayasu, we usually find our patients at younger age group, we must not forget. And it's definitely younger female, we find it more. And in case of giant cell arteritis, usually it is after 50. This is a very important point to be differentiated. And also the clinical features also, the temporal artery involvement is uncommon to absent in Takayasu arteritis. Therefore, that kind of headache is very, very unlikely in Takayasu arteritis. And usually the Takayasu arteritis patients we find in our practical life, practically we experience the patients usually have a kind of arm claudication along with uh, pulse, and so we find we record the pulse, blood pressure, and then we try to conclude in that way. Whereas when giant cell arteritis will be suspected, the other things like we have to look for, along with headache, jaw claudication, and we have to look for whether the patient is developing vision loss. Actually, the other features, along with these ultrasound findings, we have shown uh, it cannot give you the clean-cut differences. So these are the things we have to keep it in mind. So I have to repeat again, we have to depend on really mostly the history, clinical features. But again, when we will go for ultrasound, we may look at some other arteries too. For example, axillary artery. In giant cell arteritis, axillary artery is important. Axillary artery findings may help us along with temporal artery. And in Takayasu arteritis, we can look at the abdominal aorta. That may give us some differentiating points. So these are the points, and this way we should try to reach to a diagnosis. Thank you. And regarding another point, just let me finish. It's lunchtime, all we know. The difference between macaroni sign and halo sign, actually nowadays the most of the rheumatologists are not preferring to differentiate because it may be almost the same. And but when we say macaroni, definitely it looks like macaroni, that's why. But the most important point is that the thickening of the intima media, that is important. And uh, the 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 rheumatologists who prefer to say the macaroni sign, they are in favor of telling that it's a bit ecogenic or mid-echoic, not very typical to hypoechoic. So these are the very minute points to some extent. Okay. আচ্ছা ঠিক আছে ওনাকে আমরা
লাস্ট কোশ্চেন last one.
Hello. Actually, I am not belong to your specialty. I am an ophthalmologist. Have come to gather some knowledge regarding the ocular manifestations and treatment modalities having presented from the vasculitis. I am Dr. Bari, associate professor. I got one important information that especially giant cell arteritis, where we are sometimes very helpless to save the vision. You have mentioned, Dr. Minhaj, that ultrasound is doing wonderful procedure for the early diagnosis and non-invasive procedure. The Doppler color ultrasounds are being done by the vascular surgeons. I have come to know that you are doing the ultrasound. As an ophthalmologist, to whom I should refer the patient, to the rheumatologist or a Doppler or vascular surgeon? It's very vague question or very ordinary question, but it's important to me. Where should I send the patient? To both of you or especially to the vascular surgeon for color Doppler?
I think, well, so there are some overlaps, and you know these are all the bedside techniques, and if one can learn this, definitely the man behind machine is very important. And if we do not have that facilities, and if we not have facilities to have expertise, then definitely we can refer our patients to vascular surgeon. They are definitely doing this procedure for years together and so. But if one institute can develop or we have expertise, then definitely one rheumatologist or the any internist or physiatrist, anyone can do it, I think. So the important thing is that whether one has achieved that expertise, that is important. Thank you very much.
Thank you, speakers. As because we are approaching lunch, we call this session to the end. Dr.
Now I am requesting Professor Ratna Shobna to have some comment on the lectures.
At the beginning, I would like to thank the Bangladesh Rheumatology Society giving me this opportunity and express my gratitude to them to share this session. It was a brilliant session. I know everybody is hungry, and both the speakers did brilliantly. We have learned a lot, particularly from the first speaker, Professor Minhaj Rohim Chaudhry. He is trying hard to make popular musculoskeletal ultrasound in our country. He is the pioneer, and from him, we, particularly the rheumatologists and other, benefited much from the aspect of vasculitis. And the second speaker, who came from our neighboring country a long way, and he actually presented very nicely regarding the connective tissue associated vasculitis. Regarding the vasculitis, high index of suspicion is very important. And I think everybody present here will be benefited and can suspect vasculitis after this nice CME and the conference. Thank you both the speaker, and thank you BRS.
Thank you. Thank you, both the speakers and our respected chairpersons. Now I like to request Professor Toslim Uddin sir come up on the dais and hand over a memento to our respected speakers and chairpersons. Arup Kumar Kundu first, then Professor Minhaj Rohim Chaudhry. হ্যাঁ একটু সাহেব শেষ শেষ হ্যাঁ 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 and for Dr. Ariful Islam. This is for moderator. Now this is time for lunch. For the senior teachers, Ruby Hall for reserved for senior teachers, and we have 3 hall.
Okay, we can finish the session now, and we all can go for lunch, please.